Good morning. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. Today is Monday, June 16th, 2025. The time is 9:02 a.m. We're in room 123 of the John A. Wilson Building. This is being broadcast live on cable channel 13, as well as on my YouTube page at CMC Henderson. I'm calling to order this Committee on Health hearing for the second part of our oversight hearing for the proposed fiscal year 2026 budget for the Department of Health. The committee heard from over 50 public witnesses on Friday, June 6th, and the recording of that hearing is available on the council website should anyone peruse it. Witnesses voiced their support for many of DC Health's critical health programs, including those focused on healthy food access, maternal health, and early childhood. They also expressed some concerns about proposed cuts to programs across the agency, including that for HIV/AIDS prevention and treatment. I will reference the public testimony as well as the agency's budget chapter and written responses to the committee's pre-hearing questions, in today's hearing. You can find all of those materials on the Hearing Management System website on the council website. This morning, we're going to hear from Dr. Ayanna Bennett, who is the director of DC Health and her team. DC Health provides programs and services with the ultimate goal of reducing the burden of disease and improving opportunities for health and well-being for all district residents and visitors. DC Health does this through a number of mechanisms that center around prevention, promotion of health, expanding access to health care, and increasing health equity. With over 800 FTEs, DC Health is organized into 6 administrations: Agency Management, Community Health Administration, the Center for Policy Planning and Evaluation Administration, HIV, AIDS, Hepatitis, STD, and TB Administration, Systems Health and Preparedness, and Environmental Health Administration. I don't currently see any of my colleagues in attendance, but I'll certainly invite them to make an opening statement should they arise. Dr. Bennett, will give you the opportunity to make your opening statement, but before you begin, I want to go ahead and swear you in, as well as anyone on your team who might testify today. So if everyone can just raise their right hand. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia in this committee is the truth, the whole truth, and nothing but the truth? Great. When you're ready.
Good morning, Councilperson Henderson, council members who may be watching, and staff of the Committee on Health. As you know, I'm Dr. Ayanna Bennett, the Director of DC Health, and I'm here on behalf of Mayor Muriel Bowser to discuss DC Health's proposed budget for FY26 and the remainder of FY25. I'm happy to be here to talk about our investments in health. I think they've been significant. First, I'd like to, though, thank the mayor for keeping public health central to her Grow DC fiscal year budget for 2026. We know the importance health plays in helping the district grow. Healthcare is an important part of the economic landscape in DC, and access to healthcare and the resources to live a healthy life attract families and businesses to the district. Mayor Bowser has prioritized increasing DC Health's budget in a challenging fiscal year and has also made significant investments in the social determinants of health across the district, including in jobs, childcare, education, and housing. There are investments that will help improve the health of all district residents, including a $3 million investment in high-impact tutoring, $5.2 million to improve public housing inventory, an increase in the homeless service continuum of care of $18.9 million, and hundreds of millions in proposed investments for transportation infrastructure. As we move into fiscal year 2026, DC Health has embarked on a transformative restructuring to meet the changing health needs of our community. This includes the creation of the Environmental Health Administration and the alignment of our emergency preparedness and health professional and facility licensing into the newly named Health Systems and Preparedness Administration. The Environmental Health Administration includes our existing indoor and outdoor environmental programs that you know well, like restaurant and pool inspections. It also includes childhood lead prevention, which we transferred from the Department of Energy and the Environment this year. Our goal with EHA in 2026 is to work with residents and stakeholders to build programs and approaches that protect the health of DC residents and visitors, beginning with issues of indoor habitability, which is a big issue that residents have brought to us, and extreme weather and our response to the growing changes in our climate. The Health System and Preparedness Administration will bring alignment and share resources between the agency's different healthcare-related functions. Part of DC Health's mission is to ensure the accessibility and functionality of the district's healthcare system. That means that we must also support the healthcare workforce, infrastructure, health policy, and innovation needed to keep the healthcare sector robust and growing. In this next fiscal year, you will see this focus in our implementation of recent regulatory changes to the Certificate of Need program, expanded social work licensing options, and a dedicated endorsement pathway for nurses with multi-state licenses. In FY26, we're also shifting the school health services program from a contractor to DC Health staff this summer, with most of those staff coming from those currently in place in DC schools. This change will result in DC Health having a much more direct connection to keeping students healthy and staff in school, including providing direct care in the nursing suites and school-based health centers, referring students to external providers, and managing required health-related documentation. This will also allow us to explore some innovative public health interventions that leverage our new clinical workforce to address both individual and shared health needs of students. We appreciate the council's support to this critical program and look forward to its growth throughout the school year. We have also made changes to the district's animal control program. DC Health brought on a new partner in Brandywine Valley SPCA, and they launched operations at full speed starting January 1st of this year. Since initiating operations, they have supported the development of the district's new animal shelter, held several adoption and vaccination events, provided critical veterinary services for district animals, and engaged in robust community outreach. This fall, we'll see DC Health moving out of New York Avenue entirely and basing all of its services in our new modern shelter in DC Village. DC residents will also see improved customer-facing services in FY26 based on investments we've begun in FY25 that will be fully operational this coming fiscal year. We've significantly improved customer service in our Vital Records Service Center, and we'll be rolling out new modern kiosks for self-service later this year, hopefully this summer. DC Health has also transitioned the new health professional licensing timeline, which will stagger renewals based on birth date to significantly reduce renewal delays, and we'll be entering a wrap-back program to reduce the burden of criminal background checks at renewal. These initiatives, coupled with significant IT investments, will result in a more efficient and pleasant experience for our agency's customers. We'll also be launching several new strategic initiatives that have been developed in response to community and partner needs. We've heard and seen in our own data the need to focus on underserved groups and emerging and entrenched health disparities. Our priorities for the next several years will focus on reducing hypertension disparities, addressing childhood lead exposure, rebalancing the district's healthcare system to improve efficiency and safety, and addressing holes in the public health system for vulnerable groups, such as transitional age youth. Over the next year, our team is also focusing on quality improvement and health equity in our internal operations. This means significant reforms and innovations in data-driven decision-making, workforce culture, IT, community inclusion, and legal and policy infrastructure. For residents, that'll mean more efficient services and more proactive communication and response to community needs. All of this work, it assumes that DC Health's budget will contain the funding required to do these activities. While the mayor is committed generous local funding for this work, we're unsure what the public health funding landscape will look like with changes and the uncertainty at the federal level. With DC Health relying on funding from the Department of Health and Human Services for over 60% of our budget, any changes to funding for HIV/AIDS prevention, food access programs, chronic disease care, vaccination access, healthcare workforce programs, or epidemiology and surveillance will impact us significantly. Over the next few months, the federal government will make decisions that may impact our remaining FY25 budget, as well as our fiscal year 26 budget. We unfortunately have very limited information on what those changes might entail. That means we could not account for them in this budget, but we are accounting for them and various possibilities in our planning and communications as much as possible. DC Health is working with national partners to advocate for continued public health investments and is carefully monitoring the federal landscape. We'll keep the community informed with the information we have. So I thank the council and the committee for providing DC Health with an opportunity to discuss our work over the past year and our vision for the future. I'm available to answer any questions, and I also like to just briefly introduce some of the experts I brought with me who will be helping with that. Carl Filler is back there, my chief of staff, Michelle Blake Smith, my chief operating officer, Adrena Dean is here as our agency fiscal officer. Sarah Beckwith is our interim senior deputy for the Community Health Administration. Clover Barnes is going to be on screen, and she's our senior deputy for HOSTA. Sam Hurley is behind me. He's our senior deputy for our new Health Systems and Preparedness Administration. Dr. Brittany Safir is both our state epidemiologist and the senior deputy for CPPE. Arian Gibson is the senior deputy for environmental health. And I've also brought my general counsel, Lane Block, the chief health equity officer, Dr. Renina Arno, Dr. Vijay Grazat, who's our chief performance officer, and Dorothy Hale, our chief contracting officer. So you have all the information you could possibly need.
Not all the information, because now I have a bunch of questions. So we're gonna get to all the information.
That too.
But thank you for that. All right, so as you know, you have a lot of agency administrations, so we've got to get through all of them. We'll obviously take a break, and then of course, if any of my colleagues join, we'll go from there as well. We have a markup after this at 1 for the Committee on Health, so we've got some time constraints here, just a little bit. All right. Let's start with FY25 supplemental. So this is kind of an unusual situation where we're having to deal with 2 budgets at the same time. To address some of the spending pressures that have been caused by Congress's refusal to allow us to spend our local dollars. That included some hiring freezes and reductions across the government for non-life and safety functions. This also included some at DC Health. The supplemental budget includes $862,000 in one-time reductions at DC Health related to the hiring freeze. How many vacant positions within DC Health have been frozen in FY25, and what's the impact of those positions staying open? I know the city administrator recently announced that he's allowing for some waivers for some critical positions, and I just want to make sure that DC Health is taking advantage of that.
Yeah. We've gotten waivers for all the positions that we've requested them for. The most is particularly around our school health transition and other important things that really couldn't be slowed down. We did have a period during that process where some positions were left open longer than they would otherwise be, but many of those have been hired again by this point, including some deputy epidemiologists and other important positions. For the exact number, I'll have to get back to you, but for the most part, it's actually been quite a small number of positions that have been frozen that we weren't able to get a waiver for. And most of those, I would say, are not critical positions. So anything that was, I would consider life and safety. So all of our epidemiology positions, our inspector positions, for the most part, we've been able to get waivers and we're able to at least start to hire.
Oh, if you guys turn your mic on, turn the mic on.
Oh, sorry.
David.
I don't know the exact number, but we can get back to you on that. But like the director said, are critical positions and others that we need to function. Basically, we're filled or we are filling them right now.
Okay. The supplemental budget also includes a $2.1 million reduction in non-critical functions. We didn't get very specific, but what are the programs that have been most impacted by this reduction? So this would be from MPS funding.
So we've had some non-spent dollars that we were able to return from contracting that weren't going to be spent or that we thought we were doing well without. I don't think we've had any major programmatic reductions that don't fall into that category. The only things would be like delaying the fleet. We had a few things that were delayed, but they will be picked back up.
Okay. Now, before Congress kind of got involved, you all did a reprogramming at the beginning of the fiscal year in order to pay for the increased costs for the animal control contract.
Yeah.
Now, even though these were described as one-time cuts, a lot of the funding has not been restored except for as it pertains to school health. So tobacco cessation, teen pregnancy grant, emergency childcare pilot, sexually transmitted infection self-testing, the high need healthcare scholarship funding, healthy steps in the preterm birth initiative grants. Um, are those funds now permanently going to be directed towards animal control? And are we never going to pick up these functions again?
So I believe that the funds that were, most of those are being picked up in some other way. So the tobacco control, we use jewel funds to substitute for some of that that can't be used for anything else. For uh, the major movements, I think we've either found a different funding source for that or that they weren't going to be restored because there were other practical reasons. So we had more than one program where we were having a hard time getting that money out the door anyway. So for our childcare pilot, we had talked to multiple hospitals and we're working on it, but for the time frame that we had, we weren't going to be able to get that money spent. So that was one that,
Okay, what about the high need healthcare scholarship?
so that scholarship is now up and running, and that money is not going back to the scholarship, but we have moved other money into that area. So we're actually still giving out the same, if not
Okay,
more.
how much is there now
I'd have to ask.
or planned for FY26? Gotta use your mic. I can hear you. They can't hear you.
My apologies, Adrena Dean, Agency Fiscal Officer. So for FY26, there's approximately 900K for the high needs scholarship. In FY25, I believe it was 1.3. So while there was a reduction, there is still funding.
And you said we're up and running on this program.
Yes.
All right, so is the application live? Like, what does that look like?
So the way the program was designed is that the funding was given to educational institutions who then give free admission to students who apply. So those grants have all been distributed and we should be able to start to see students taking those up. Some of them are operational in the summer, but many of them it'll be fall students.
Okay, so we'll be able to assess the impact in about a year.
Yep.
Okay, all right.
Councilmember Henderson, the exact amount is 993,000 for the high needs scholarship.
Thank you. All right, let's go to CHA. So the FY26 proposed budget includes a $2.4 million reduction in personnel funds for the healthcare access program due to reductions in federal and local funding. Are these reprogrammings or are these RIFs?
We did do some riffs in CHA. Thank you. We had a couple of different funds, not just that one, that we lost on the federal level.
That again, please.
Sure. So I'm asking about the healthcare access program. There was about a $2.4 million reduction for FY26. You all said it was due to reductions in both federal and local funding. And I was just wondering, are these reprogrammings or were there RIFs?
So there were, some of that is the loss of the immunization funds that would have ended anyway. We were able to spend out a lot of that funding because of the injunction against that rescission. And so those were planned term positions that went with COVID-related dollars.
Okay. Were there any full-time positions that have been lost as a reduction?
Yes, and they were going to be lost because they were term positions, so they weren't permanent positions.
Right. Let
You
me
meant
ask again.
permanent. They're
Permanent.
No, I
Okay.
don't believe we did any permanent
No.
positions that way.
No.
Okay. There's also a proposed $560,000 reduction in the grants line for the healthcare access program. Which grants are we losing here?
I believe those are still COVID.
Yeah, so those were grants supported through the COVID-19 funding. And we had some outreach grants and some home vaccination grants. So those programs are being concluded.
Okay. Are we making any investments locally in terms of immunization funding, given the federal government's kind of iffy stance towards vaccines?
So we haven't planned on any additional dollars there. We have not seen any reason to think we're going to decrease the amount we get in terms of vaccines for children or the grants, the vaccines that we give out. a lot of the policy decisions you're seeing are going to impact everyone. So those are around what insurance companies are bound to give you
Right.
and things like that. So those are really more across the board. So far, we have not seen a reduction in vaccines for children
Mhm.
or the vaccine administration dollars that go with that. So no, we haven't, but so far we don't believe we need to. But again, there is some uncertainty in what they will do. I have not preemptively invested in areas that seem like they might be threatened because
Okay.
there are lots of areas. And so we can't really know what to take from to give anything to until we get some real decision making on their part.
Okay, that's fair. The FY
I just,
20, oh,
one more thing.
yes.
I will just say the COVID dollars were meant to enhance capacity and to give us room to learn and figure out how to do some things. And that is exactly what we did with them. So it is not a net loss in service per se that people were getting. We can do mobile vaccine much easier than we could before. We have a relationship with different contractors and FEMs that we didn't have before. So the dollars serve their purpose.
Yeah.
And we had
in terms of
plans on
strengthening
advancing.
the overall
Yes.
immunization infrastructure, which is great. But, just this weekend, you all had an alert out of someone who measles, right?
Mhm.
So, just because COVID isn't necessarily, COVID still exists,
Yes, it does.
just because it is not the more prominent conversation item doesn't mean that there are other needs in
Yes.
terms of vaccine awareness, particularly around some of these new emerging or re-emerging diseases.
Yeah. If
Okay.
we lose our own capacity to do it, if they cut our grants, then we will see that in the vaccination rates around the district.
Okay.
So far, so good.
The proposed budget support act would turn the communicable and chronic disease prevention and treatment fund into a lapsing fund, with any balance reverting to the general fund at the end of each year. What are the revenue sources for this fund?
Say it again.
Communicable and chronic disease prevention and treatment fund.
Oh, this is awesome. Sorry, the titles of the funds don't necessarily go with the administration they go to. So this is the HOSTA fund that comes from the drug dispensing program. Yeah. Can you describe it? I don't-
Or
Clover.
Clover's here.
There she is. She came back. Clover, do you want to describe the funding sources for that? I know it's out of drug dispense, but I want to give her.
Sure. Good morning, Clover Barnes, SED of HASTA. The fund is from rebates that are collected from our AIDS drug assistance program. And they are funds that come from when we pay the insurance for people who are living with HIV and they go and purchase drugs. We can get them at a lower rate because of the Ryan White program and the Public Health Service Act. It's like 340B rebates that come to us from the medications that are purchased.
Okay. Are there any staff positions or other purposes? Sorry. Are there any staff positions that this fund supports?
Yes.
How many?
I believe about 18.
Just for clarity, did you
And the
say?
funds have to be used to support HIV programming. So we use the funds every year completely. It's part of the statute.
Okay. So two things. One, because you kind of cut out. Did you say 18?
Yes.
Okay, 18 positions. And you're saying that the funds have to be used to support HIV/AIDS. So why are we okay with it reverting to the general fund?
We'll talk to them about it. We actually aren't allowed to spend it on anything other than that, or we lose the rebates. So the funding source would go away if we don't spend it on HIV related services. So we're in discussion with them around that.
All right. Good to know. We'll add that to our BSA change list. Okay. There were a few grants with vague descriptions that we want to try to get some clarity on. There's one called Chronic Illness Initiative. It was $239,000 with grantees listed as various. What is this?
So we have used this funding to augment our cancer and chronic disease prevention initiatives. We used it this year to support the Howard University Hospital Sickle Cell Center to do outreach. We used it to supplement our DC Poison Control Center. And then we've also used it to supplement our breast and cervical cancer screening programs.
Okay. All right. There is one also referred to as team-based care for chronic conditions. It's 1.5 million.
Yes. So we use that to support a federally qualified health center to lead oral-based healthcare initiatives to increase oral healthcare services for underserved individuals. And a majority of the funding has gone to our lean transformation grants. So we're working with 3 federally qualified health centers and a hospital to improve how they operate and deliver primary care services in order to be able to see more individuals.
Sorry. Just there's some other parts of the government that also has grants around oral health. So we are just trying to make sure we're not duplicative in terms of efforts. Okay. Dr. Bennett, in your testimony, you referenced a new focus on disparities in hypertension. We heard from several public witnesses about the need for focus on men's health. How will your hypertension investments and other related chronic disease efforts address the disparate impact on men?
So hypertension is one of those areas where men are more affected and also less successful at accessing care for their hypertension. So that is where the focus of that work's going to go, into looking at men in areas of the city we know have higher rates of hypertension and also have lower rates of hypertension control, which means you're not in effective care.
Okay, so I just want to pull this out and tease this out a bit more
Mhm.
because I had a lot of witnesses across your hearing, DBH, healthcare finance, et cetera, who were, at first it was a push for an Office of Men's Health. Then it was for grants specifically around men's health. Can you all talk a little bit more besides hypertension around this issue? Now, obviously, in the DBH realm, when our work on substance use disorder is overwhelmingly impacting
It's
Black men.
Mhm.
That doesn't mean that women are not impacted, but the number of individuals who are dying of fatal overdoses in our city, we know are disproportionately Black men. There are other health conditions, prostate cancer, stroke, hypertension, heart disease, diabetes, et cetera, where we do see still some spikes and differences. And I just want to give you an opportunity to speak to this and also how you respond to the request for additional funding and focus on this area.
So I am always interested in where the disparities are, and men are more affected than other groups, particularly Black men, but really men across the board. If you look at many of these problems, for all of those things you mentioned, we are working in all of those areas at this point. I believe hypertension for sure has a focus on men and especially Black men. So does our work in prostate cancer. So does much of our work in diabetes and other chronic disease. Part of what we are looking at is the why. Some of that is about access to care. And so looking at where our care access numbers show where men are not getting the care that they need, looking at what parts of the city those men live in. So I agree with them that there are significant disparities in the health of men, and in particular, the health of Black men. It is the driver of most of our life expectancy differences, are these differences in health and healthcare access. I'm not In general, I would prefer, rather than just to set up an office, that we have individual projects that have actual hard outcome goals that we can measure and see if we succeed or fail. Sometimes we put in administrative infrastructure, but unless that administrative infrastructure has an endpoint, um, I'm not sure people get out of it what they thought they were going to get out of it. So we are in those conversations. We've been talking to different groups about particularly hypertension and prostate cancer in Black men for some time now, and people will be seeing more investment in that area.
Okay.
But again, that the caveat is that as the chronic disease federal world is unclear right now, the offices that supported that work have mostly been riffed. The grants still exist, but it's unclear who is administering them and what the future of it is. But that, like all of our work, the vast majority of that work is going to be funded that way. And so our ability to do any of those things is a little bit unclear right now.
Okay. I would encourage that. So, in our budget report, there are a number of different things. We go over all the hearings, et cetera. We also make some strategic programmatic recommendations on to the agencies. It's good to hear that you all are planning some of these projects. I would just ask that you all be more communicative and vocal about what you're doing specifically, because I can kind of see how, even in this conversation that we've had thus far in this hearing, right? We've talked about breast cancer and cervical cancer screenings and money and grants specifically for that. We've talked about some, specific things that are related to women's health. So I could kind of see, perhaps in theory, how some men feel there isn't a specific program focus for them within the department. Um, Now, obviously, there's a lot of cross-cutting pieces that are there. So as you all are moving forward on some of these projects, and I personally, I'm looking for the sort of outcome-based piece. My pushback to these witnesses was, we have an Office of Health Equity who could be focusing on and doing some of this work. To just create an office to do what? I'm not entirely sure, and not interested in necessarily, I don't want to say wasting money, but having it sit in an administrative action as opposed to something that could actually be working to help change outcomes.
Well, where the funding exists to add new programming, we will. What I will say is that some of what people are seeing is in fact appearance, because there are particular life experiences or organs related to women that tell you that that's a project for women. So when we're doing maternal health, it's obviously that's maternal health. We have for at least the last year, been focusing on what we're going to do around Black men and hypertension. Those programs are only just sort of ready to push out. But if it's hypertension, it doesn't feel like it is only about men, because it won't ever be only about men. It's about everybody. Maternal health's a little different. Breast cancer, it's not only about women, but it's so overwhelmingly. So some of that is just the way in which that childbirth experience kind of separates. But all of the things in which we see disparities, our goal and our practice is to target the disparity. So where will our dollars and our time and our investments actually make the biggest impact? And that's on the group that's the most affected. It doesn't mean that everyone won't benefit from a better, more efficient, federally qualified health center. But what we're asking them to do is, how much outreach have you done to Black men? How much outreach has resulted in people doing visits? So that's where our outcome measures are, and we will be doing a better job about sharing those going forward.
Great. All right, let's switch to school health for a minute. And I want to say at the offset of this conversation about school nurses. So I had a couple of people who reached out once DC Health put out the press release, and they were like, "Oh my gosh, did you know anything about this? This just came out of nowhere." And I was like, "It didn't."
Yeah.
And I want to assure folks that we have been talking along with Chairman Mendelson about what to do about school nurses for several months now, especially acknowledging some of the concern and discontent that parents, school leaders, and others have raised about vacancies, but also what they feel like is the interaction day to day. So you all introduced on May 5th a reprogramming within DC Health for the transition, the school health services program in-house starting in June. Again, for the public watching, this was a plan fleshed out by DC Health and Children's School Services over the last year. Dr. Bennett, before I get into specific programmatic questions about the
Mhm.
budget, I want to give you an opportunity to describe the rationale for the transition as well as your goals for the future of the program.
Well, there are two sides. One, children's school services felt that that was not an area with all the other things that are happening in healthcare right now where they could continue to put their focus. They, like all hospitals and maybe more than some, are having to really look at where their services are in terms of Medicaid and the other threats that are coming down the pike. So they wanted to change their focus. We have long been working with them on how to do a better job of overseeing the program. It's been a long time that there's been a gap between what we can do and what actually happens on the ground, because that is how working with a contractor is, and we had wanted to bring it in-house on some level for that reason. So we had already had some staff come in last year to talk about redoing curriculum and how might we do better in terms of metric oversight. So that work was already ongoing when Children's let us know about this decision early this calendar year. So we have since then been working on the mechanics of how to do that transfer. Needless to say, the congressional budget issues have not helped because we're talking about transferring a large number of staff. Our goal is to keep them all where they are and work on the quality and other issues in the program once it's over. But it has been a very large lift for budget and for HR and just internally administratively for us. And so we have done some communication, but partly because of the waiver system and the way in which everything got more complicated. While we got lots of help from the city administrator's office and the budget office, they waived whatever we needed them to waive. But the time involved did take longer and it was a little bit more complex. So all of those things have been a focus for the moment. That does not mean we have not been already and will continue to be focused on the structure and quality of the program. So the curriculum for training that everyone's going to go through, yes, they've already been trained, we're going to retrain, is going to start this summer. We'll be looking at how they interact with each other and what our IT systems can do to make those interactions better. One of the things that I want to be clear is that our health techs are there and can provide lots of levels of service, but it is really not supposed to be managing decisions where things aren't totally clear, and that is where they should be calling in the nurse or the chief medical officer or other folks and making those lines of communication much, much tighter. So there will be changes in the program, lots of it in the back end on how we work together and not necessarily visible to parents, except hopefully it'll smooth out some issues that people have seen.
So let's talk a little bit about the people piece.
Mhm.
So the transition of a contract will create 222 new FTEs
Yep.
at DC Health. That'll bring you guys to over 1,000 FTEs.
Yeah.
Which I think makes you the largest in the health cluster. You're already the largest in the health cluster, but this blows it up just a hair bit more. How are your HR and IT offices preparing for this?
So some of what's going to happen is that what is overhead in this contract that had been going to Children's, we're going to have to make some of that still overhead and have more HR and IT support for the program.
Right.
What's happened is we don't already have those things in place as we're transitioning it over. So it has been a really big lift. And I basically dragooned every person who works in HR on something else, and other things have had to be delayed in order to get all hands on deck to get hiring packets and the rest of it through. So we will have to grow those areas of the department. There is enough funding. We know that this program can fund both the overhead and the salaries. It will continue to do so, but we're in a position of having to grow that overhead
Okay.
capacity. So that is a little bit of a transition stress, I would say.
Okay. So even though we've been talking about this for months,
Mhm.
and we already started to move the funds in the FY25 budget, the proposed FY26 budget chapter for DC Health only moves
Yeah.
funding to create 50 new FTE positions.
It's an error.
Okay. That's 172 FTEs that's still on the contracts line.
Mhm. It was a version error. So the actual numbers are in with the mayor's staff and in our budget, and we've done all of that work on our side.
I know, but these positions have not been
It
created.
hasn't
So
been-
somebody has to fix it.
That's not, yes, they do. For 26. For 25, we have created them. The hiring packets are going out as we speak. So that transition, that reprogramming and everything needs to be fixed so that those can be, those positions that we are creating right now will have a position to continue into in 26.
Yes.
But we have focused on it.
Okay. Have you guys started these conversations with the CFO's office? Because the
Yes.
council budget office does not have the capacity to create your 172 new positions.
So we are prepared to submit the reprogramming for FY 26 at the earliest submission time that we can submit for FY 26.
Okay.
But we are fully prepared to do that. It's no issues with that.
Okay. But how does that disrupt your transition for the start of the school year?
It won't, because we're going to start the school year with the staff that we're hiring right now over the summer.
Okay.
So we will be able to continue those positions while this process is going on.
Okay. Of the children's school services folks, how many folks decided to stick with you guys and transition over?
We're still awaiting responses, so we don't know, but over 200 of them did all the paperwork and applied. And so they have to accept their formal offers, which they have not quite all received. They're going out right now. Our expectation is that if you did all the paperwork, that most of them are interested in continuing where they are. And that is the message they gave us. So we are expecting many of them, but we also have a contract with a registry if we need to fill in any positions that people don't take.
Okay. So it sounds as though, and I just want to say this for the record for people, that we're continuing with the cluster model
We are.
for school year 25-26. What management improvements do you feel like can be made so that we don't have what we had last year
Mhm.
of some health checks who weren't necessarily following protocol when
Yeah.
a significant health situation did arise?
So the issue is always one of how team-based care operates. It really is a continuous endeavor. So you have to have talked every day. You have to have ongoing communication and huddles. And that is not, the structure is not very robust in that manner right now. But when people are physically distant from each other, if you're not proactively doing something that makes them still a team, continuing education together, at least every few day huddles to say what kids are in your school, what are you worried about, and then continuous trials on different kinds of emergencies. You really can't train someone for an emergency who has a day that is full of routine stuff and expect 6-8 months later that they're going to behave in that emergency in the way that you expected them to when you trained them quite some time ago. So that is why we were working on continuing education and that infrastructure with those 8 positions that you gave us last year. That is what those people have been doing. So that infrastructure is already prepared to deploy. It would have deployed within the children's staff. It will deploy within our own staff. So we expect there to be far more routine and continuous communication and then far more rehearsal of emergencies.
Okay. In terms of these new folks, which we're excited about, welcome. We're excited for them. Are they going to sit in CHA? Wait, are you creating a new division? I mean,
Yeah.
love you, Sarah, but that would make
It's a
CHA
lot.
the
I know.
largest administration at
I know.
DC Health.
So we are currently, they are sitting in CHA, but I have given up my chief performance officer who is doing all this all the time for some time. Thank you, Victor, to give it an executive sponsor. We've added some other administrative support. This has essentially been some of like animal control was a thing that has engulfed the administration and used all of our resources. So all of the HR decisions and all the work that's being done is being done right outside my office in a conference room with the head of HR and the head of IT and the head of everything. So right now it's got a lot of administrative support. So CHA is doing some work in that it is in their budget. So they're budget folks are working on it, but for the most part, it has not been a burden on Shaw. We do need to reorganize, but we're not going to do that right in the middle of trying to do the transition of all of the staff, because just the HR and IT and other burdens are too much right now.
Okay.
So we do know that we need a different organizational structure. We don't know what that is, but we will work on it later this summer once
Yep.
all the staff are on board, and we'll be in discussion with you about what that'll look
My
like.
gosh, all of your future all hands meetings will be taking place at an arena.
We
There-
have,
I
we
mean,
have
like-
learned to use virtual in a way that I think is exciting and will work for everybody.
Okay. So we heard some testimony from the Georgetown Medical
Mhm.
Legal Partnership that operates out of both Anacostia and Blue High Schools, school-based health centers. In the pre-hearing responses, DC Health states that 7 school-based health centers will operate in FY 26,
Mhm.
5 in-house, 2 through a contract with Unity. What's the rationale for moving most school-based health centers in-house, and will this help the program be a bit more financially sustainable?
It will probably not have a huge impact on its financial outlook. We're just going to bill and cover the services as we can. What it will do, though, is give us some consistency across what is done in each high school. We've had multiple different contractors running essentially different programs in different schools, which is not a really good way to improve anything. Utilization at most of the schools has been fairly low, and that's in the context of us having real health issues that we'd like to work with students on. So this is a bid to get some more consistency. We're going to leave the 2 most heavily used centers in the hands of the groups that have been running them so far, and that's Unity. Both of those schools are run by Unity.
So that would be Cardozo and Woodson?
Yes.
No, Cardozo and Coolidge, sorry.
Coolidge, sorry. We will start running the other ones, and that'll give us a consistent program across all of them. And it will help link it to the rest of school-based health. They've been run very separately from one another. So there's been the health suites, and then the clinics have been
Yeah.
somewhat divorced from each
So
other.
most of your school-based health center, not most, all of them are within high schools.
Yes, they all are in high schools.
Which is a little bit different than
It is.
providing care for elementary
It
school
is.
in terms of the number of services that they come through. And I know you said that they're not a lot of visits, but I don't want to minimize the fact that some of these schools have like over 1,700 total visits in a school year. Considering that they're only 180 days in a school year, that's
Those are the 2 larger schools.
Yeah,
That is going to continue.
Cardozo has 1,700, Coolidge has 1,400, Woodson has 1,300. So you have 3 that are
Yes.
really, and then the others are not necessarily seeing the same number. Now their student population is a little bit different in terms of the number of young people who are on those campuses. So what's the plan in terms of staffing? A school-based health center is bigger in size than your normal traditional health suite.
Yes.
And then again, right, they're doing, let's see, sexual health visits, asthma care, oral health, behavioral mental health, et cetera. How do you all plan to sort of augment that or staff that appropriately?
So we're going to staff it in somewhat the same way. It's a little bit more clinically focused, and we are more than happy to work with the Medical Legal Partnership or other partners. In fact, we can certainly work with any of the people who are running them now if they would like to offer some kind of service within the school. What I'd like is to have a consistent base across all of them, and then augment that with partnerships as they come in. We are going to focus on youth high-risk behaviors and youth mental health and things that I think are unique to the high schools, not unheard of in the lower grades, but really are a much more adolescent health model, and not simply trying to do all things for all people, but really trying to focus on having the youth be part of the management of the clinical spaces and what kind of services do they need.
So how many hours per week can one expect for school year 25, 26?
It will differ. We're going to keep it the same this year,
Okay.
unless we're able to expand it. But we expect to move it to full-time at all of those as soon as we can.
as an aside, but while it's sort of on top of my head, we should talk to Unity
Mhm.
about their, wait, I'm sorry, is this a contract or a grant? I get,
It's a contract.
okay, we should talk to Unity about their contract for one of the sites, given the other proposed changes to the Alliance program.
Okay,
Okay, I'll leave it there.
noted.
All right. Okay. So at the performance oversight hearing, you testified that both the school-based health centers and school health services program are working towards being able to accept Medicaid reimbursements. Have you guys handled that with healthcare finance in terms of becoming a provider, I guess?
Yeah, it's not finalized, but they're in process.
Okay. Do you feel like that's going to be in place for the start of the school year?
I'm hopeful it'll be in place for the start of the school year.
All right. Okay, so in the pre-hearing responses, you all described that full implementation of the Access to Emergency Medications Amendment Act of 2023
Mhm.
will be fully happening in first school year 25,
Yeah.
26. However, it also states that 2 of the FTEs who are supposed to be helping to run this position, who you all told us you absolutely need in order for this program to go forward, are unfilled because of the hiring freeze. So
We
how,
do need them.
okay, are we gonna,
So
oh,
other people have stepped in and we have managed to get it. It's still going forward, but it will need more support. I'd like to put people back to what they are supposed to be doing.
I know.
So
And
we make it work because we need to.
great appreciation to everyone across the agency for just kind of
Yep. Hey,
stepping in to fill in where
yes,
they
that is
where
what
they
we're
can.
doing.
All right. Also at performance oversight hearing, you testified that DC Health is working with DCPS to enable families to upload their universal health certificates on
Yeah.
their Aspen portals. Yay. School year 25, 26.
We have a lot of IT happening
Okay.
right now.
That's
So
great. Every agency across this
we have so
government
much.
plussed up their IT costs. So like, let's use
Well,
these.
it's because we needed to.
Okay.
But I don't know where that particular project sits at the moment, but it's on the list.
Okay. You
I
also
can check
testified.
on, I'll follow up with you on it.
Okay. You also testified that DC Health was in active conversations with OSSI about not requiring the UHC every year, but only when there is an update.
Yeah,
Have those conversations?
I don't think we've moved as far forward as we would like to with that conversation, partly because we've been, now that was before we were taking over school-based health. But that is still my intention.
Okay. So I would just tell you, so I got 2 kids in DCPS.
Mhm.
When I submitted their enrollment stuff, I had to, or they gave me an option to upload the UHC
Mhm.
as part of the enrollment stuff, which I'm like, okay, great. Now let me see if in 3 months you're going to ask me for the same document that I already gave you. Let this be a test.
All right, let's see.
Um,
Love a test.
all right. As you know, the committee is exploring transferring the school-based behavioral health program
I do know that.
from Department of Behavioral Health to DC Health. I want to state for the record that DC Health did not request this. But for a host of reasons, we do believe that, especially if you guys are going to build out some sort of specific administration that's focused on school-based
Mhm.
health, that this fits in terms of ease of management.
Yes.
How do you envision the program aligning with DC Health's missions priorities? Is this an opportunity? Are you guys still apprehensive? How are we feeling?
Everything's an opportunity. I don't spend a lot of my time apprehensive, so that's just at baseline. But I do think there are areas that we can use the alignment with the clinical health programs that we're already going to be running. It is rare that the two are so entirely separate from one another. Children's health, for the most part, takes place in their pediatricians and regular clinic offices, and their mental health, for the most part, gets taken care of there until they need something more than that. And that is the model that I would strive for. I don't know enough about school-based behavioral health right now. We definitely need some time to ramp up. I'm very grateful that it doesn't put us trying to do that this summer at the same time we're trying to transition all of the health suites. But we are prepared to learn what we need to learn, and I'm quite comfortable running a clinical program of any type. And we will need some in-house expertise on that, but we will get that, and then we'll be moving forward.
Okay.
I think I have the infrastructure to do it, so I'm prepared to do whatever's asked.
We'll obviously follow up with your staff, but at this point, it is not an October 1 transition
Thank you.
because that would be not silly, but it would be irresponsible for us to try to do
Thank you.
that right now. So we're going to build in a transition timeline so that by the time we get to the start of school year 26-27, the hope is that this program will have been moved over.
Okay.
Okay. On May 8th, DC Health announced in the Register a federal grant referred to as Pediatric Mental Health New Expansion. What is this?
I'll actually have my
early You got to turn your mic on, Sarah.
Sure. I'll actually have my early childhood division chief, Dr. Erica Peterson, come up.
Thank you, Erica.
Thank you.
Good.
Hello.
Hi, how are you?
Good.
My name is Dr. Erica Peterson. I'm the Early Childhood Health Division Chief for DC Health.
Great, Dr. Peterson. So we're asking about the Pediatric Mental Health New Expansion federal grant. We're wondering what it is and how it will be utilized in the district.
Okay, the Pediatric Mental Health Access Grant is a grant that we have from HRSA that we actually have an MOU with DBH to provide services. And actually, they actually subcontract with Paving the Way, DC MAP, to, are we talking about something different? Okay.
No,
That's it.
I'm just curious. Keep going.
Okay, and DC MAP actually provides support to physician offices around behavioral health services as well as mental health services. They provide consultation, telehealth, training and education to the staff.
Okay. I was just only looking like that because DBH hasn't ever mentioned it as a thing that you all do jointly.
Yes, this is a program that was initially under the child and adolescent, well, the CASH, what is still a child and adolescent health program, which recently became part of the Early Childhood Health Division.
Okay. All right. Hold on one second. Don't go anywhere because I'm looking for the next question that is relevant to you. Hold on.
Okay.
Just so you don't have to come back and forth. All right. So the pre-hearing responses indicated that there's some changes to the federal and locally funded home visiting programs out of DC Health for FY26.
Okay.
Can you summarize some of these changes and the effect on specific programs and grantees?
Okay, sure. So.
Yeah.
All right, so in terms of changes, currently there is no anticipated changes in federal funding for our home visiting programs. There is a minimal change in local funding through the home visiting, it's not birth to three, the home visiting preterm. home
Oh, it's
visiting-
preterm birth initiative?
Yes,
Okay.
preterm birth initiative. But in terms of the change in structure, our federal grant through the Maternal, Infant, and Early Childhood Home Visiting Program that we affectionately call MCV, that particular current project period is ending. And so with the end of that project period, we have decided to release a competitive RFA and provide more funding to more local implementing agencies versus one local implementing agency.
Okay, so the impetus for that change was simply because the previous project is ending and therefore it's an opportunity to do
It's an
something.
opportunity, yes.
All right. So the responses that you all sent indicate that the 1.2 million in McPhee grant for Mary Center in FY25 is no longer available in FY26. I just want to be clear that as opposed to funding one organization, that funding will now be competitively offered.
Yes.
Yes.
Okay, so I
And if
guess,
they're the only person who tries to get that money, then it'll go back to them. If there are several groups, then we will try to do several groups to try to spread to different populations.
okay, so the new competitive grants, I guess if I did the math, would amount to what you gave all to Mary Center in the previous one, sort of. It's a 313,000 each plus three plus another grant for 300,000.
Correct.
All right. So when do you all plan to release the RFA for that? I guess it's the RFA process.
Yes, actually, we have, think it was released last week. I want to say it was released last
Oh,
week.
already up.
Yes.
Okay. Okay, cool. Moving forward on that one. Okay, hold on one second. Okay. Do you do Dr. Peterson healthy steps too?
I do.
Again, I'm trying to be efficient here.
Thank
That's why I'm
you.
like
Thank you.
going through. Okay, so we heard some public testimony about the importance of healthy steps, especially from early childhood providers. Given that there's several federal and local funding streams for healthy steps, can you confirm whether the program is decreasing, increasing, or remaining flat?
There is no anticipation of reduction. It is remaining flat. So the amounts will be the same this year as well.
Okay, so then a budgeting related question. There are two separate grants that we have that are listed as healthy steps. One is for 1,050,000,
Okay.
and then there's another one for 300,000, but there's no contractor identified for that second $300,000 bucket.
I would have to get back to you on that because we currently have, in terms of our grantees for Healthy Steps, we have Unity,
Mhm.
Community of Hope. We also have Children's National and Georgetown MedStar.
Okay.
So we have 4.
All right. So if the budget folks, if we can get together to figure out why there are two separate contract grant items, I guess we want to know how much should the healthy steps part be? And if there's a typographical error and there's an additional $300,000 floating around, we'd love to know that too. Great. Okay. So there is a proposed FY26 budget decrease for the preterm birth reduction initiative grant. It was at 1.6 million. It's now going down to 1 million. In the pre-hearing responses, DC Health described that the reduced funding was due to budget pressures and reductions per grantee. That was based on performance. Now you all gave us sort of what the new proposed reductions would look like, or sorry, the new amounts. But there is one grantee that appears to not have made any progress towards reducing preterm births. I am curious why they are still being awarded if we were making reductions based on performance. I love
think
Dr.
that's what-
Peterson was like, nope, not
That's
not it.
Thank you.
Oh, it was already on. There you
Good
go.
morning, Lenita Williams, Perinatal Infant Health Division Chief at DC Health. And the entity that you're referring to is on a corrective action plan that has been initiated due to outcomes and also funding delays with invoices and monthly reports. Since the corrective action has been initiated, those reports have been timely as well as invoices.
Okay.
The outcomes that we have seen with that entity also reflect their low population that they serve. So where our other entities, their patient numbers are very high.
Yeah.
That particular entity, they don't service the same number of patients. And so outcomes also are a
Harder to
little,
judge.
yeah, they look much lower. However, they have made efforts in terms of hiring folks. They've hired like a perinatal coordinator that has been able to help us get some data. And so we are seeing some movement with them. We are working with them to also collaborate with some of the other preterm birth organizations to be able to help, because a lot of them are feeder organizations to that entity. And so that's
Okay.
where we're working around.
So the grantees that had seen the strongest results were also seeing a reduction in their grants. So I guess I'm trying to, like, what was the rationale for this sort of equal, everybody gets a decrease approach, as opposed to us continuing to strongly invest in the ones who are seeing the best outcomes?
So we did, with the proposed distribution of FY26 funding, each entity did get a reduction. However, the entities that were the top performers got the least. And we also know that as we did have to make some tough decisions. However, some of those same cornerstone components of the preterm birth reduction grant, such as centering pregnancy, such as perinatal navigation, are also priorities under our federal grant. And those opportunities will open up for additional funding for these same organizations for the next 5 years. And so we're confident that while we did have some reduction for preterm birth, we do have other investments that are pretty solid for the same type of programming that will ultimately reduce preterm birth.
Okay. The proposed funding for the Perinatal Quality Collaborative is
Mhm.
flat at 350. But DC Health chose not to continue the council's one-time enhancement for the Kick Stillbirth Initiative. It's about 75,000. Why did we choose not to continue this funding? The responses indicated that we've received baseline data from this initial funding investment from the DC Hospital Association. Sorry, I just had letters here. I was like, which acronym pieces? So are we gonna be able to continue tracking us stillbirth outcomes without this funding?
Yes, so that one-time enhancement allowed the DC Hospital Association to produce marketing and communication materials to distribute throughout the birthing hospitals. That is on its way. And so the production for those items were allowable with that funding. And now we're moving towards sustainability for the next fiscal years so that we can embed that work throughout the Perinatal Quality Collaborative. The work won't end because the enhancement is ending.
Okay. Are there any cuts to the Safe Sleep Program funding? If so, how much?
There are no cuts to the Safe Sleep Program.
Okay. All right. So the proposed budget includes a $735,000 competitive grant for teen pregnancy prevention. In the past, this has been a sole source situation, but you all are now choosing to do this competitively. What's the rationale for that?
We are choosing to do this competitively to allow organizations the opportunity to be able to provide services for across the district and to see as we move into a different fiscal year to see what opportunities we have. We know what has happened through previous iterations of this program. And so we're looking at the evidence, we're looking at what our partners are saying, and we want to be able to create something that makes sense for the adolescents in the district. Things have changed in recent years, and so we want to move with the times. What is the data saying? And the competitive RFA allows us to be able to do that.
We also know prevention dollars in this space are really important right now. So
Mhm.
I'd like as many opportunities for organizations to move into this work
Okay,
or to
so
bring this on if they have been doing this work.
unlike some of the other grants where you all have said we anticipate 3 grantees in this particular area, there's no number here. So I guess you're just gonna see what comes available and try to go with, or
Well,
or is there a minimum grant amount?
I don't think so, partly because people have not been in this space before. And so we may be getting folks who are just starting or adding this to another program. So
Okay.
I think we're interested in seeing what's proposed from our perhaps new partners.
Okay. All right, let's talk tobacco.
Mhm.
Okay. So the FY26 proposed budget reduces 2 grants for the tobacco cessation
Mhm.
by a total of 850,000. You all said that part of this reduction was due to the CDC ending the tobacco control cooperative agreement in April of 2024. I hate that I'm asking this, but did they give you guys a rationale as to why they were ending this cooperative agreement?
They did not. I think we saw the priorities come down from the federal government. And so we saw significant cuts across the Office of, and I'm not going to get this name correct, but the Office of Tobacco Control. There were cuts to asthma, to Alzheimer's. So no, it didn't make sense. No.
Okay. All right. I know that you had said, Dr. Bennett, that you all plan to, I guess, supplement some of these cuts that
Mhm.
are happening on the federal level by using the jewel funding. But my understanding is that the jewel funding was tied to, in some ways, a specific age group. So what are our plans for adults as it
Yeah.
pertains to tobacco?
I'm going to let you answer in a second. So part of what's happening at the federal level is that it's very unclear what will reemerge. So there has been at least the plan proposed that when the Administration for a Healthier America gets pulled together, that some of the chronic disease and tobacco money will return. I'm not counting on it necessarily, but
Okay.
it's unclear whether whatever has happened this spring is what they intend to go forward with. And we seem to be having gaps in funding just to end things and then to start something new some other time. So we don't actually know what we're going to look like is my only start.
Okay.
And then at the moment where this is part of what we do in the rest of chronic disease. So it's not disappeared entirely, but yeah, it does need a source of funding.
Okay. So,
that-
oh,
oh.
go ahead.
And that 800,000 was actually, we reprogrammed 350,000 into personnel so that we could continue to support some of our team members. And it actually ends up being a $500,000 reduction to the total $1.9 million in tobacco settlement fund. So we still have a significant amount of funding
Mhm.
to carry out our statewide tobacco control efforts.
Okay. All right, so let's talk a little bit about the Jewel settlement funds. FY25 budget dedicated 771,000 in FY25.
Mhm.
And then it was 853,000 in the out years for DC Health on tobacco and vaping reduction efforts. Have you all had any hurdles in that funding making its way to DC Health from, I guess it would have started with the Office of Attorney General and then it would have kind of moved over?
I want to say no, but Adrina,
For FY 25, I have not received any information in reference to the dual settlement.
Oh, wait, hold on. Does that mean you haven't gotten your money?
We have funds in local for the dual settlement in FY 25. Tobacco funds. We don't have any special purpose revenue funds today.
Yeah. Okay, so we'll follow up with you. So we had to create a special purpose revenue fund because this was specifically settlement funds, so it's not otherwise, but it's supposed to go from OAG into the fund and then go to you guys.
Yeah.
So if you haven't gotten your 771,000 for FY 26, or sorry, FY 25,
So for 25, it's in the budget, but it's in local. The 771K is there, but
Okay.
it's in local. I assume that going forward in FY 26,
it should be in.
it should be in a special purpose revenue fund. But it is in the budget in 25. It's not in the special purpose revenue fund that you mentioned.
Okay,
It was put as a one-time item in FY 25 for the 771K.
right. So is there any money in 26 that they've?
The 771 was not restored in 26 in local.
No, I understand that part, but did they give you any?
Nothing is in the 26 budget.
Okay. There's money there. So we just need to make sure it finds its way to you all. Okay. In the pre-hearing responses, DC Health transferred 141,000 to DCPS in FY 25 to supplement DCPS's health education manager position to prioritize tobacco prevention.
Mhm.
Mhm.
But that line is zeroed out for FY 26. So this was funded in part by the settlement.
Mhm.
Why are we cutting it?
I was not,
We're not,
there are no plans to cut it. So
it's just, we're waiting for we don't have the funds to.
So you're
apply.
just waiting for the money?
Yeah.
Okay,
There's no plan to cut it,
but DCPS still has this position?
Mhm.
In
Yes.
theory?
in theory,
Okay.
they do.
unless something happened with the settlement that we don't know.
No, I mean, the settlement is a settlement. The money
Then
is
we're
the
good.
money. So we just gotta make sure it gets to the right place. Which is no problem. This is an easier one to sort of solve.
Yeah, that
Uh,
can still be allocated. It may not be in the proposed budget, but once the MOU is signed, the funds will be allocated.
Okay. And what are we using it for beyond the manager position?
We are supporting two inspectors in our environmental health administration to carry out inspections at retail stores to ensure that they are adhering to the tobacco 21 law and the flavors law. We are putting out a request for applications now to lead enhanced youth engagement activities and a mass media campaign that will focus on vaping and marijuana prevention.
Okay. All right. Let's back with why you're still there. Let's talk about food access.
Food.
Okay, so the mayor's budget presentation, her budget director, I'd asked the question about food in terms of FY 26. Her budget director wasn't under oath at the time, but nonetheless said there were no cuts to the food programs in FY 26, except for when we look at the responses around the healthy food access, we do reduce 50,000 from Produce Plus, as well as 50,000 from the Joyful Food Markets. What were the rationale for these reductions?
To meet the mark, we did make those reductions with Joyful Food Markets. We plan to be able to supplement those funds with our USDA Emergency Food Assistance Program, TFAP. So Joyful Food Markets is eligible to be a TFAP distribution site so we can make up for that gap. And then with Produce Plus, we are currently applying for 2 USDA farmers market promotion grants. And so we should be able to address that gap.
Okay. Just for the public to know, $50,000 in Produce Plus is an equivalent of 200 additional participants being able to get benefits, which is significant. And 50,000 in Joyful Food Markets is 4,166 bags of produce. So that's also significant as well for what I think is a smaller investment, but the impact on the other side. So there was announced this into the local food purchasing agreement, federal grant. Was this anticipated by DC Health or was it terminated early?
So I'd like to express appreciation to my team, who is awesome. We are continually applying for outside funding opportunities. So this was a time limited grant. So it was always going to end. From USDA. They did indicate that they'd plan to release another round of funding that would have started in FY 26. And unfortunately, that was dialed back when it was determined that because this grant worked to create sustainable ordering pathways between BIPOC, so Black, Indigenous, people of color, food producers, and nonprofit food distributors. It was determined by the federal government that it
this got
didn't
cut
meet their,
DEI.
yeah.
They may repurpose it and we'll see.
Oh, it's only been 6 months. Lord, help us. Okay. So the majority of the Fair Food for All Coalition's budget asks this year was focused on anticipated federal cuts to nutrition programs. So I think it's hard for you guys to predict, but which federal funding streams do you foresee most likely to be cut, and where would you recommend us prioritizing filling in holes? Is that one of the conversations I'm having with my colleagues is around how can we make this budget on the local side in such a way that we can sustain or soften the blow to some anticipated cuts that we know might be happening. Thoughts on that?
Our problem in predicting is that the rhetoric on one side does not match the rhetoric on the other side. So the rhetoric around fiscal changes is about big things like SNAP, which have a huge impact on people's food access. And the rhetoric on the Health and Human Services side is that food is medicine and food insecurity is more important than other health interventions. So I can't tell whether or not big changes in order to make fiscal impact are what's going to happen, or whether some of this health focus is going to result in money being retained in those things. I would be most concerned about the large scale cuts in Medicaid and SNAP because those are so foundational for everything else. A lot of the things that we do with Health and Human Services almost assumes that those supports exist and that they are, in fact, playing around the edges where there's high risk or high need and then targeting. We will have the same problem. What we want to be able to do is have some kind of basic foundational support that gives people access to food and healthcare. And then we can say, why are Black men not getting their hypertension medicine? Why are pregnant women not getting quite enough food? If that doesn't exist, then I'm not sure we'll be able to target in that way because the need will
Be
outgrow
greater. Yep.
whatever we can do. So we're struggling to do that prediction. The results of the reorganization on the HHS side supposedly will be done by the end of the summer and we'll see something, but what's said about priorities versus what offices were ripped out of existence, they seem comfortable with there being just a gap in service and that not necessarily reflecting how they intend to go on.
Okay. Okay, that's fair. All right, so grocery access pilot program.
Mhm.
You guys had the funds last October, but we're not distributing them until July 1. Help me, help me. You guys are
Yeah.
usually much better about getting
Yep.
money out the door. This is a very long delay. And we intentionally designed this program so that the agency wouldn't need to create anything new. And that we could distribute the funds quickly. So this is very disappointing that we've had such a delay on this.
The contracting process and working back and forth with our legal teams at the entity that we're aiming to contract with has been extended. A good news is that when the fu- funds for the membership are distributed, the individuals will receive those monthly funds to cover the cost of the membership for a full year.
Okay.
So even though we are delayed in getting the funds out, they still will have the opportunity to.
It will
use
go until
Yep.
July of
Yes.
26.
Yep.
Yes.
Okay. Now your responses state that 80% of the beneficiaries are SNAP Ed participants. Even though the Budget Support Act says that all of them should be SNAP Ed participants, I just want to give you opportunity to clarify what happened in terms of the decision of who can get the access.
I think in that response, we supplemented, so we used this local funding as an opportunity to enhance it. And so we used federal funds to support a cohort of about 200 patients at an FQHC. And so they are part of our pilot and they were not served through SNAP Ed.
Okay.
Yeah.
All right. So the tough part of us not starting until July is that now in the middle of a budget process, I don't know, do we
Whether it
put
worked or not.
funding in to do this for another year? You all didn't include the 120,000. So what's your recommendation here?
So the local funds are paying for the memberships, which will keep going. And we'll be looking at the data from what happens there. So if we don't do any funds in 26, we will have time to know whether or not the funds from 25 were effective. I would suggest that's a short time to be piloting something.
Yeah.
And so I would recommend that we commit to be doing that for a couple of years.
Yeah.
So my recommendation would be that we also include it in 26 if that is something that's possible. But we are not in a bad position if we cannot.
Okay. I agree. 1 year is not enough to make any determinations about change in behavior and those kinds of things. Um, because you also have some federal funding that is kind of in this space, is it possible for us to lower the local contribution with the expectation that federal funding might be there to augment in the future?
Let's get back to you because we need to be able to be sure what the federal funding can be used for.
Okay,
Just to be sure.
sounds good. Okay. The Nutrition and Physical Fitness Bureau. I don't often talk about them. I don't think I've ever talked about them. Anywho, their budget is increasing by $3.9 million due to increase in federal and private grants. What's going on there? And yay, federal money or private. I don't know, somebody not us.
It could be that we have fully transitioned the.
It is some.
Yeah. Um,
There's a reorganization to put two things together.
Oh,
And so, yeah,
okay.
sorry.
Well, I'm gonna take back some of my excitement for the
Okay.
future. Okay. All right. So WIC,
Yes.
at Performance Oversight, you all testified that you were working with healthcare finance to integrate WIC enrollment
Mhm.
into DCAS, DC access system. In the FY25 budget, there was a, was/is, 75,000 one-time in MOU, between you all and healthcare finance for the software development for this purpose. It's not funded in FY26. So are we to assume that you all were successful?
yes. So we are at the end of the sprint, which is terminology that DCAS uses. We have made, adjustments to DCAS when an individual is applying. There will be high level eligibility determination for the Women, Infants, and Children program, so that individuals, when you're in either, when you're in the DCAS app, if it looks like you are eligible, a pop-up message will come up, saying you might be eligible for women, infants, and children. And here's how you can apply. And that will happen at a couple different places in the application process for Medicaid, TANF, and SNAP. And then the second part of that project that we will work on this year is creating a modified environment where women, infants, and children program staff, when a family comes in to apply, to help reduce the paperwork burden, we'll be able to look in a modified DCAS environment at their household income. And then be able to enter that information into our own database. And that is on track and will be completed by September 30th.
Okay, sounds good.
Yep.
All right, so, I'm gonna do one more administration and then we're gonna take a break. That sounds okay with you guys. I'm trying to decide who is small enough for.
Before you move to the next administration, can I clarify one thing?
Sure.
For FY25, while there was a 771 for the dual settlement, there was one time, there's also a 854K that is a recurring line item.
Okay. Great. We don't have to go talk to the OAG and say, where's your money? It's lovely. Great. Okay, I'm gonna do, CPPE.
Okay.
Okay.
Come here, Dr. Brittany.
All right, so this administration has an overall decrease of about 842,000 in personnel services and 607,000 in special purpose revenue in FY26. Did the administration have to make any RIFs, and what is the impact on these cuts on research and programs?
One, I wouldn't describe them as cuts per se, because it's the end of COVID funding. And so the things that we were supposed to do with it, we did, and then it ended, thanks to a little help from the injunction, it ended as it was supposed to end.
Okay. Is that
Go
for
ahead.
all of that funding that I just talked about?
Yes, I believe for the majority of it, it is that some of it is revenue based through our Vital Records Division as well as the SHIPTA program. And so some of those projections change over the course of the year.
Yeah, I mean, a $600,000 drop in a special purpose revenue fund. Did we have less people requesting things, or did we change the fee structure?
I would think it was less people requesting things.
And more online, but more went to the vendor than to us.
Okay. At the performance oversight hearing, I asked about the status of several maternal health reports,
Mhm.
which you all assured us will be published in the second quarter of fiscal year 2025. We're now in the fourth quarter.
Yeah.
Okay. So, and none of the three have been published yet. I just kind of want to know where we are. So I've got a natality report from 2019 to 2023. The reported pregnancies and pregnancy rates information and the perinatal report, all waiting.
So one of them is completed and just waiting for EOM's review. Is it two? One of them's on my desk. Pregnancy is on my desk, not their desk. It will be on their desk. Maybe tomorrow, maybe the day after.
Okay.
And then the third is the natality, and that one's still,
So the third is the perinatal health
oh,
one,
right, parent
Yep.
health.
and that one should be closed out this week and moved up to Dr.
Part of what happened is we waited a little bit to get the rest of 23 data and to look a little bit at prelim 24, so I could understand where I was. And then we needed to make an overhaul of how we report stuff. So it's been a little bit of a back and forth to get a better quality report. Sorry about that.
Okay. So when
We
should I
will
start bugging the
communicate,
city administrator?
next week
Great. He
on
likes
two
those
of them. One
text
of them,
messages from
yeah.
me.
on two of them. One of them is still in production.
Okay. CPPE lists 6 new dashboards that are going to be rolled out this fiscal year as well as in FY26.
Mhm.
I'm curious what order we should expect these in. Although that's not really fair to list all 6 and then you to tell me which order, but
Yeah.
so let's just talk about, I'll name them and you tell me like expected timeline. How about that? All right. So DC Prams.
Rams is just about finished and should be completed by the end of the fiscal year.
Okay. DC BRFSS. What is that?
Burfus.
BRFS, it's the behavioral risk factor surveillance study.
Is
And that
this-
one, oh,
I would say that's one you're probably familiar with, of us calling people and getting a sense of what their views on their health are.
I know,
So
but
if
you
have
call it
diabetes- It's called
Burfist?
Burfus. We didn't invent it. It's a federal program.
Behavioral what now?
Risk factor.
Risk
surveillance.
factor.
surveillance study.
Okay.
Mhm.
Just be coming up with anything. Not y'all.
I think it came to me. with that name.
Universal, y'all. Behavioral risk factor surveillance survey.
Uh-huh.
I feel like I'm adding every day an acronym to my cheat sheet. Okay. Sorry, what was the timeline you said on
So
that?
that one should be done by the fiscal year as well.
In the fiscal year. All right. I'm gonna put September on all these because that's technically. All right. Natality dashboard.
So the natality dashboard, along with mortality and morbidity, should all be done by the end of the calendar year.
Okay.
We are in the process of doing some data cleaning and trying to get the FY24 or the calendar year 24 data to be included in that dashboard.
Okay. Is there, I guess. All right. So you have one that's named mortality, one that's named morbidity, and then one that's maternal health or sorry, maternal mortality and morbidity. So I'm assuming mortality, morbidity without maternal is everybody else or all other things.
So the mortality and morbidity will include the maternal mortality. But we're doing also a separate one just so that that population can have more direct access to the information.
Okay. So all of these for end of calendar year.
Mhm.
Got it. Okay. The budget includes a 238,000 MOU to the Office of the Chief Medical Examiner to create a system that will collaborate on prevention and intervention efforts to mitigate accidental overdoses in the district. Now in FY25, this MOU was for 421,000. So this is a little bit of a reduction, but can you elaborate on the purpose of this funding and then why the reduction?
That's OD2A.
Yeah.
That's the CDC's overdose data to action grant that is intended to give states the ability to look at what's happening around overdose so that we can plan our interventions around it. So it is the thing that gives us the dashboards that you may have seen. It's the grant that gives us the alerts when we're having a spike. And so a lot of that data comes from the Office of the Medical Examiner, and that is what that grant is for. I think the grant itself had a reduction.
Well, and the FY 25 had some expanded authority to use funds from a previous grant year.
Oh, okay. All right. The last death with dignity report was released using 2022 data. What's the timeline for the 23, 24 reports?
I don't have a direct timeline for that one, but I can follow up on it.
Okay, just so you know, the last report and the one before that, they're super short. I think it's like a page. It's a little chart. How many people? That's it. So, given the unusual interest by some Republican members of Congress on this particular program, it would just be helpful to so that everybody there's some transparency there because they're suggesting that we're letting all these people do things or we are
Oh.
directing these things to happen when in fact
Got it.
I think it's probably very small numbers. And
not
so
relevant.
it doesn't have to be fancy. I don't think the report calls for anything fancy. I think it's just what are the numbers? Okay. All right. All right, let me do Shipta real quick.
Okay.
Okay. And then I mean Shipta's still in PPE, right? CPP?
Uh-huh.
Okay, okay, great. Wonderful. All right. All right. So the proposed budget support act includes the subtitle State Health Planning and Development Agency Amendment Act of 2025, which clarifies that SHPTA is under the direct control of the Director of the
Mhm.
Department of Health. Why was this needed? And what's the connection to the budget? Now I have to ask the
And have
connection to the budget. Because we're trying to take stuff out that doesn't have a budget nexus. Go ahead.
Okay, so we were the health systems reporting, the health care and health status reporting are all separated and in fact budgeted as separated, which does not make sense. It's not the best way to do data-driven decision making. And so I'd like them all to be coalesce and to be the same people and to have more flexibility around that. And so the community health needs assessment, the health systems plan, all of those things will be in one group together. And so that is what that was about, is getting the data function, which is really a whole of DC health function, along with other sources of data. So SHPTA was asking for data from these groups. They were asking for data. I'd like them all to be the same group, and that's how we've reorganized it.
Okay. The subtitle changes the non-lapsing SHPTA fund to a special fund that will be used to pay SHPTA and other DC Health salaries and expenses. And then it will be swept into the general fund at the end of the fiscal year. What have the balances in the SHPTA fund been in the last 3 fiscal years?
What had they been?
Yeah.
I would have to look it up. I can get back to
Okay.
you.
We would love to know that. The point that we would get to is that if there has been a significant balance in these funds after paying, X, Y, or Z, might that be the impetus for us to lower the fees for CON as opposed to allowing, I don't know how much money, but to just kind of sit?
Yeah.
You know what I'm saying?
I think we've already made a change to CON, so I'd rather not have 2 changes at once. So because there are some entities that won't need CONs and we have some activities won't need CONs, we do still have to have the office do the work that's in the statute.
Mhm.
So I wouldn't want to make any further changes until we see what the results of that change will be.
On the funding piece.
Yes.
Okay. All right. Well, it would just be helpful for us to know for the budget report purposes to have a historical look at how much money has actually been in
Right.
that fund.
But some of it will be quite different, right? Because there's money from various CONs that won't happen again.
Correct. All right. Okay. So my staff is hearing a little bit in your responses that you guys are already planning for changes to CON, even though the bill was not funded. Does that mean that you're moving forward without us giving you all of these additional FTEs that you have requested and some other things?
While we can't make someone do a CON for their construction costs that now the statutes, well, I'm assuming that we'll somehow have to move forward on some of it.
Okay. I was hoping you were going to say, oh no, we're moving forward and we've already,
If we,
and no, council member, you
So,
won't
but
have
the
to come up
law-
with
the
these
law
brand new
says-
FTEs to do this
the law
thing.
says we do have some parts of it, we will need FTEs to do. Telling the public you don't need a CON for something, I don't know if we can stop them from not doing the CON for
Yeah.
that, whether or not we have, that's
I
not
mean-
the part we needed staffed for, so that
Sure.
will go forward.
I would say most, if not any of the lobbyists or lawyers who work in the CON space, they know the law is not implemented until it is funded.
I know.
They keep emailing me about the funding. So they know they're in aware
Yes.
of that piece.
I am making an assumption.
Okay. All right. At performance oversight, you all testified that out of the 5 hospitals who had not met their uncompensated care requirements for fiscal year 24, 2 had submitted correction reports. What's the status of everyone else?
So we are working with the hospitals to continue coming up with compliance reports so that everyone will be in compliance with their uncompensated care.
Okay. Have we imposed any fines yet?
We have not imposed fines. We have taken the approach that as long as people are working with us to accomplish the goal, that imposing fines is not the constructive way.
I
of
love that
moving
you all
forward.
try to be so collaborative, but what's the point of having a fine if nobody ever uses it? As long as I'm continuing to work towards getting you possibly the thing that you've asked for, there's no consequence.
So for those that we have had some other providers that weren't moving forward that we have set firm dates for,
Okay.
that told them that they were going to get fined if by this date we're not in compliance. And that did encourage them to move forward with compliance. So having it there to exercise has been constructive,
Okay.
but using it for just because we have it has not seemed to be the collegial way to work.
We're looking at all of our fines and our fine structure to see where we are need to reevaluate how much and when we use them. So we'll talk more about that and you'll see some regulatory changes around that.
Okay. As an aside, similar to other things, if there are in fact some changes on the federal side as it relates to forcing states to change their programs, their health programs that exist for individuals who are undocumented, we might need to come back and have another conversation about the uncompensated care requirements and the overall impact on providers and hospitals going forward. Normally that's a conversation. Well, that particular program obviously sits in healthcare finance, but I want to make sure that everybody's at the table in terms of the various impacts that could have across the board on all the things. Okay, we've been going for a little bit now, so let's take a 5-minute break. When we come back, we'll start with Hosta and then we're making our way. All right, thanks. 5-minute break. All right, so, and we're back. Okay, so I want to start with Hasta. Oh, yep, she's there. Great. Okay, so I know, bad for me using acronyms. For those who don't know what HASTA is, it's the HIV/AIDS Health STD. Nope.
Hepatitis, STD, and
HIV,
tuberculosis.
AIDS, hepatitis, TB, STD administration.
Anyway, better known as HASTA.
Mhm.
All the things.
Mhm.
All right. So unfortunately, there are some significant cuts to HASTA budget due to losses of federal grants and contracts. In responses, DC Health notes that the CDC grant PS 24-47 for HIV prevention and surveillance was not awarded as planned on June 1st, 2025, and there has been no communication from CDC about the grant. DC Health has had to issue stop work orders to the subgrantees for this. How many subgrantees do we have, and what was the total amount that was expected?
There were about 14, and it was a little over $2 million. The amount that was expected was 6.3 million for the whole award, but the part that we stopped work on was a little over 2 million.
Okay. You mentioned that you all did not discontinue the prep housing or the PEP hotline, but that both would have to be scaled back this summer. What are the funding losses for these programs, and what will be the impact of those cuts?
Prep housing is about $400,000. And that would mean that the 8 gentlemen who are housed in the program would be unhoused. Right now, they're slated to have their housing covered for 2 years through the program, as well as their prep. And so we would still be able to cover their prep at the Health and Wellness Center, but we would no longer be able to cover their housing. And then the PEP hotline is a 24-hour hotline access for people who may need post-exposure prophylaxis because they think they've been exposed to HIV. And we would have to stop those services 24 hours. We would still be able to offer them at the Health and Wellness Center when it's open, but we would not be able to fund the portion that goes 24 hours. And we would probably have to limit how much medication we could pay for through the
I just want to
program.
clarify, we have not been told this money will never come. What we've been told is nothing. And so, no,
Is that better?
it is different because there is some concern that what's happened is the money from the Office of Management and Budget going to the CDC, that there's been a problem in that area, and the CDC is trying to scramble to figure out where they can pull money from, but they're getting money in short-term bursts that don't give them enough to fund any of these programs. The money is appropriated. It is in the, it is,
Oh.
yes. But the spend plan and the administration of actually moving the money has not happened. It is very unclear that this is a policy decision of any kind. It could be we're going to administer this in a way that makes it not happen intentionally, or we are not administering anything. It does seem as if this is not isolated entirely. We're waiting to see other grants that are coming up, whether they will suffer the same problem of the money just never showing up and not getting a communication that it will. The CDC cannot tell us the money is coming until they actually have the money. And that is the place in which things are failing. Not that they haven't said, at least, that they intend to not give it to anyone, but they definitely don't have the money to give us.
Okay. I can appreciate the optimism, except for we've got 8
No,
people.
we have no choice but to do with what we're doing. We don't have any choice.
Okay, what's the timeline? What's the last possible day? Right? Like, we made a commitment to 8 individuals
Right.
that they would have housing for 2 years. This doesn't seem like a significant amount of money that, while I understand we're waiting on it from the federal side, we have an interest as district government to keep these folks
I know.
housed.
There is no commitment that even if the money were to come, we would be able to spend it in that kind of retroactive way. They have clarified that they can't say that that is how it will happen, if it happens at all. So we have no choice but to stop unless we are pulling that money from somewhere else. And I don't have that to pull from something else. That would be a policy decision on what other kind of programming we would prefer to stop. So we have not assumed that we're going to get something that they have told us nothing about.
That's fair.
But
And
the reason I brought it
also,
up
we've
is
got
that
a
it's
whole,
not isolated to them. There are other funding things that are coming up that I don't know 100%,
yes.
that this may happen again.
I think though, housing is different than a hotline.
It is.
Hotline, we can augment, again, you said this stuff can continue at the wellness center. The housing, that's 8 people. So are there any conversations happening with other housing agencies around whether or not they can backfill this? This is FY25 money, I'm assuming.
Yes. Right now, there's no other program that funds prep housing or funds housing for people at the highest risk for HIV. Our other funding for housing is around people living with HIV.
I understand. Okay. So I don't know anything about these individuals, but let's suggest that they might have, if they're receiving behavioral health. I know DBH has a bunch of money that they haven't spent on housing. So what
We'll
I'm
talk.
asking is to have, let's try to be creative here.
Okay, let's talk to our
And
partners.
talking to our partners who have funding available, particularly in the housing space that they haven't used yet. I can't remember how much DBH has, but it was about this, if not more, because they have vouchers that have gone unused.
Okay,
That funding could be used for that.
thank you.
Okay. So we heard significant public testimony about the HIV education and prevention services funding cuts, including the Women's Collective, a number of individuals who testified, some very powerful testimony on that. The budget indicates that this program overall is losing 2.4 million, predominantly from grants and contracts. Is this part of the same CDC grant that we were just discussing?
Yes.
Okay. So is that the 14 grantees? Or
Yeah.
is there
The
more?
Women's Collective is one of those 14 grantees.
Okay. I guess I kind of answered the second question that I have, but I guess it's a different question. I asked a similar question to DBH, right? Like, if we look at our opioid funding in the district, we spend nothing locally. All of our opioid funding is tied to federal money from SAMHSA or settlement funds. And it feels like that is similar what we have happening here in HIV. So then my question is, if the federal money all goes away, do we just not do HIV prevention anymore? Because we're not making any investment, it feels like, with local dollars in this work.
We would have to make some policy decisions about what other things we would stop doing. But yes, we are heavily federally funded in areas where the federal government has been willing to fund. And then we have used local funds to shore up areas where they are less willing to fund.
Yeah. Okay. I'm gonna keep all my personal comments about this administration to myself. All right. So I want to go through a couple of other programs within HOSTA just to understand the impact. So the HIV/AIDS Housing and Supportive Services Program is being reduced by 655,000. What's the impact of this reduction?
I think that's a right sizing of the grant. I don't think our housing program has a reduction at this point. There is one possibly coming based on whatever Congress does with the budget, but there is not a reduction at this point.
Okay, the HIV Policy and Planning Program appears to be losing over half of its funding. It was at 2.8 million at FY25. It's now down to 1.3. What's the impact on the staffing levels here?
Yeah, I think most of those that you're gonna bring up now are a right sizing of the grants between the fiscal years. You know, we lost money last fiscal year. And so that money was already in the budget formulation coming into FY 25. And so the budget had to be right sized to make it appropriate going forward.
Okay. The STD control is losing 784,000 in federal grants. That's about 30% of the program budget.
Yep.
What will we not be able to do?
All of the CDC funds help fund the STI, the Health and Wellness Center, prevention, all of that rolls together. This is all the same funding.
Okay. So I mean, are are we getting rid of the Health and Wellness Center then, or?
No, 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 no. We're not
Okay.
getting rid of the Health and Wellness Center. No, we you know, when we made the cuts that we got last year, when the grants combined into PS 240047, we eliminated some positions, as you know, about 17, and then 5 vacant positions. And then I mean, 5 filled positions. We eliminated 17 vacancies and 5 filled positions. And then we had to decrease what we did overall in the grant space. And so those cuts have already taken effect in this fiscal year. So those are what you're seeing reflected in the budget.
Okay.
Hopefully some of that work at the wellness center will be billable, and that's part of the impetus to actually try to recoup Medicaid dollars for healthcare delivery that's happening there.
Okay. The HIV/AIDS data and research is losing about 571,000 in federal grants, which is about 20% of its budget. How are we going to ensure that we're going to be able to continue to keep up with our data and research on this effort?
There are a couple of things. There's one grant, our NHBS, which is the National Behavioral HIV Surveillance, I think it stands for. That one we've already been informed is going to be eliminated, and it ends at the end of the year. And so that is just work that we won't be able to do any further. It basically interviews different populations on cycles for who are at the highest risk for HIV. So that's one that we know we do in conjunction with GW that will go away. It is in that same DEI executive order elimination. But surveillance is covered by PS 240047 as well. And we would have to figure out how do we cover surveillance with funding that we have that surveillance staff would be allowable on that grant to pay for.
Okay. So I have a meeting with my colleagues tomorrow to talk various things in terms of the budget. In an ideal world, I want to be able to hand them a list and say, I know you might have your own personal wishes, hopes, and dreams of what you would like to send money to for the health committee, but here's my top, like based on our hearings and our conversations with agencies, fund this instead. Not your pet project. This is where the highest needs are. If we had to prioritize in terms of HOSTA, what is the biggest area where we should be focusing or encouraging colleagues to focus their activity?
HIV prevention and surveillance for
Yeah.
sure. That's where the money is at highest risk. That's where we haven't received a notice of award and where other funding can't cover those services and those programs. So that would be our biggest ask.
Okay. Is that the 2.4 million?
Yes.
Okay. Righty. Okay. Okay. Would it make sense to fund that one time because we don't know what's going to happen next?
So we're going to have HIV service reductions. They're just, that part has been made very clear. Whether or not they happen this way or they happen in another way, that is a piece of information we do have, that there's going to be a significant reduction. What I would say is that if we are not funding the exact same activities as are happening right now, we would have to be funding something else in the HIV prevention space. So I would say it will need to be an ongoing investment if the federal government is on an ongoing basis much more out of this business. But any transition is better than what we have right now.
Which is a complete cutoff.
Right.
Got it. Okay. Get Check DC.
Mhm.
Imagine we're going to continue this program. How is it going to be administered in FY26? You all said during performance oversight that we've been relying a lot on community organizations in fiscal year 25, but you hope to bring back the program to its original design in 26. So what's our thoughts going forward?
Unfortunately, that program is funded, other than the portions that you all so generously funded, is funded by the same funding that we don't have a notice of award for. So without an additional notice of award, we wouldn't be able to continue the program. Our goal was to create enhancements to the website where residents request the HIV kits that it verify their address. Because
Yep.
what happens is we get a lot of return kits that come back to us. And so it's like a rat race to try to get the people the kits. But we weren't able to create that enhancement because of the lack of funding. And so we have been still relying on our community outreach endeavors as well as providers to get the kits out to clients. So
Okay.
we handed them out at Pride, we handed them out at Black Pride, we handed them out, anytime we're in the community, we're invited to a health fair, we bring them and give them to residents who are there. But we weren't able to operationalize it in the way that we intended.
Okay. We heard testimony from the executive director of Joseph's House asking to restore the $400,000 grant. They asked for an increase, which everybody does, but the proposed funding level for FY26 is 340,000. Was this just a meeting the mark and every grant had to take a hit?
Yes. They also got funded this year through Ryan White, which they were competitively awarded a grant to come back into the network this year.
That's great. I didn't know that part. So that's good that they're getting some funding somewhere else. I think that, like, I've been to Joseph's House, and just sort of the idea that it was established as hospice, but they do such a good job getting people back on track that folks are able to leave and go live independently, which is beautiful. And I wish that we had that level of success happening in multiple places. All right. Finally, on the hosto piece, I want to ask about the sexual health peer educators grant. So we funded this last year.
Mhm.
Now, in the pre-hearing responses, you all said that you awarded this to the Latin American Youth Center to operate a peer outreach model. I was not aware that LAYC had any sort of sexual health model out of there. Is this operating in high schools as required by the subtitle? You know, the responses you all sent indicated that the model will be focused on youth from 13 to 24 as opposed to just high school students. So why did you all make that change, and why didn't you communicate it with us that you plan to do so?
So LAYC has been a HIV prevention provider for many years. They have a fairly robust program
Mhm.
for STI and HIV prevention, working with young people in particular. We know that 13 is the age of consent in the district. And so while it is focused in high schools, they do allow 13-year-olds to participate in the program. It is not a change in the location or the emphasis of the program, but
Okay.
it's in addition to allow them to seek services should a 13-year-old come and want to receive services.
Okay. So I know the funding was awarded in January. Your responses said that LAYC has had some challenges recruiting peer educators, but plans to have the positions filled by the end of June. So what is the plan in terms of I guess, the implementation of this grant, considering the school year's over. So what is going to be their model going forward?
We know that most schools have summer school active and summer programs, and so they are engaging with those programs to recruit and to have programming for the young people.
Okay. Is there funding to continue this program in FY26?
I don't think so. Adrena, I'm sorry, I don't have the budget in front of me.
No, I don't believe that there's anything noted specifically in the budget for this. I will double check, but just out of my recollection, I do not believe so. But let me double check that.
Okay, thank you. All right. Okay, gonna go to HISPA really quickly. For any of the council staff who are watching, if your bosses were intending to come to the hearing for DC Health, they should make their way. Or give us a heads up that they're planning to attend because, you know, I've got like 2 administrations left, and then I'm not gonna hold DC Health here while y'all get here. Okay, just so you know, Adriana, we on your what is this? Attachment 1, you all list LAYC as having 150,000 for this grant. Okay,
I confirm.
Okay.
I just put it up myself.
okay. Then let me ask the follow-up question. If Clover, did you leave?
No, she's there.
No,
Okay,
I'm still here.
okay. My question then for FY26 is, are you going to competitively bid it, or are you gonna just continue with the same grantee?
I think we would continue with the same grantee. I don't think the program can make an impact in a year to know whether or not they did a good job.
Okay. Okie dokie, thank you. All right. Hello, Dr. Hurley. Good to see you. Okay, so at the performance oversight hearing, DC Health testified that you're working on a software updates to the health licensing system
Mhm.
on the applicant facing side. Yay.
Yay.
Have any improvements been rolled out for our fiscal year 25, and what improvements are planned for the rest of fiscal year this and going into 26?
Gonna take some time.
Okay.
We are still looking at, our plan is to try to work with a vendor and look at systems functioning well in other states. And rather than build entirely new, that is what is currently available. So we are still looking at, which one of those we'll use, and we haven't contracted yet, but it'll be a slow transition. We'll have to transition a profession at a time kind of thing. Once they get, our specifications, the point is to not have to build out a whole new thing, but to make tweaks and specifications for DC based on whatever product is available. So we should be able to start seeing something once we get all that signed, but it'll be in FY26 that you'll see changes start.
Okay. In that sort of IT realm,
Mhm.
there is still no online complaint form that someone could submit about a health professional. Like, if I had a doctor behaving badly, I have to type it up, scan it, email it to you guys, and hope for the best. Or is it fax? Oh, I print a form on your website. I have to fill out the form and then I have to send it back to you, as opposed to me doing this electronically. What's the delay? Because you already have an online form for health facility complaints. So if I want to complain about a doctor or someone in particular, why is this such a different process?
Good morning, Aisha Nixon, Associate Director for the Office of Health Professional Licensing Boards. So we did update the form so that it is fillable. We will be working with Octo to facilitate us having the similar submission as the facility side.
Okay. Octo's great. People don't use them enough. They did wonders for DCPS in their after school sign up program. Okay. On this, and I guess separately, but also curious, if somebody wanted to check to see if somebody was licensed in good standing, how would they do that?
So on the website, it is a licensure lookup site. So it's a verification site that is linked directly to our Salesforce, which is the vendor that we use right now for our applications. And so individuals can pull up the, go to the website, look at the licensure lookup, enter the person's name, and they would be able to see their license status. So it will demonstrate when the license was issued, the license type, when the license is set to expire, and if there is any discipline.
Okay, so anybody can look that up.
Correct.
All right. I'm asking that because I was reading this article about this administration and sort of all the individuals that they've just named to this vaccine situation. And the person lists a number of universities for which he is supposedly a professor. And then the university, one of them here in the district, was like, no, he don't work here. And so then it made me think, did anybody actually check the license to make sure that this person was in good standing before they joined this national federal board to like advise on immunizations? Just a thought for the federal people who listen. Okay. The proposed budget cuts 2 FTEs from the health licensing staff, one health licensing specialist, and then 1 pharmacist. In the response, DC Health states that these cuts are critical to timely and effective licensure, which I'm confused. So why'd y'all cut these people?
It was done inadvertently. It was not intended for us to cut them. This was done during a like, budget exercise, where we had to identify positions and non-personnel services from every administration and every office. At the time, my office had no vacancies, and so we made proposed cuts for both our funds, our special purpose revenue funding, so the health occupation fund, and then the pharmacy protection fund. So the cuts were identified for both, and unfortunately, it was accepted for the pharmacy protection fund.
We do have the fund, there likely will be funding in that fund to cover these positions. We've been talking about, and with the mayor's office, about what would be in those funds. Go ahead, Adrena.
Okay, so that's my question. I think these are funded through the Health Occupations
Yes.
Fund. And there are adequate funds in the SBR to
Yeah.
cover these folks?
So formulation was based off of the mark estimations for FY 26. And there were some reductions that had to be made to meet the estimated marks provided by the mayor's office.
Okay, nope, that wasn't my question. My question was, is the money there to cover these people in the fund normally?
Yes.
Okay. All right. I mean, in that same regard, so the Budget Support Act would turn the Health Occupation Regulations Fund into a lapsing fund, with any balance at the end of the year reverting to the general fund. So considering that we fund our health licensing staff out of that, what's the impact here?
So it will be, the fund has been a little bit variable and a little bit feast or famine when you had 19,000 of one professional at once in a month or two, and then you had nobody, and then you had 8,000 of another profession. Now that everybody is moving to a more monthly cadence, it will even out the fund so that there won't be 9 million sitting in the fund at the end of the year that we're hoping to save. It'll be a much more consistent amount coming in. That being said, potentially, if you have a bolus of people, you could lose funding that you need, but we should be having more funding coming in because there were people born in August or September who will then be needing to renew. So it won't be as dramatic an impact as it would have been 3 years ago, but we will need to be planning ahead to be sure that we will have the funds for all of those positions.
Okay. My inclination is to keep this as non-lapsing as you all go through this first year of
Changing it.
everybody renewing on their birthday as opposed to all at one time. Is there some other reason I should not do that?
No.
Because according to the CFO, there's no physical impact. So,
I can't tell you that there would be necessarily,
okay.
but I also don't have the data to 100% predict.
Okay. The other thing too, for me, and this is the case with a bunch of, right? You guys are not the only funds. I've named a couple. I think there was like 40 something funds that they're trying to make lapsing that are currently non-lapsing. Some of them where it's profession based, right? I, as part of this profession, paid this fee into this fund for this specific purpose. In this case, fund the staff that processes my accounts and blah, 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 blah. Then I'm okay as a part of that workforce to say, this is the reason why, this is the reason why I'm doing this thing. So I want to sort of keep that connection and on that front. Give me just a second. Sorry about that. Okay. Sticking in sort of the licensing piece, I want to ask about another BSA subtitle about the Wrap Back program
Mhm.
with MPD. Okay, so I went to MPD's hearing last week. This has come up in multiple cases because there has been a suggestion of some colleagues to remove the MPD subtitle from the budget, but then you guys are kind of tied up in it in the same way. So you have a proposed subtitle called the Health Occupation Criminal Background Check, which authorizes the mayor to use the Wrap Back program to also conduct criminal background checks for health licensed professionals.
Yes.
All right. So my understanding from MPD is that the Wrap Back program is only so that there's continuous monitoring,
Mhm.
not the initial check.
This is for renewals.
Okay. So I just want to, because that part is not clear in the BSA. And then when I brought this up to MPD, the chief, as well as her budget folks, was like, "Oh, no, we can't do everybody."
It's for renewals.
Okay. But that's still a lot of people.
It is a lot of people.
Do you foresee any changes in the fees for applying for criminal background check for health professionals? Like, how much does it cost for a Wrap Back versus if I was just doing it normally?
So currently the fees are set at $50 every time you apply for a license certificate or registration.
Okay.
And so I think the plan would be is the way that the RAPAC system is set up is that you're gonna pay the fee, but it lasts for 5 years. And so we don't anticipate that there's going to be a major change in the amount that it costs. It might be a slight increase, but then the criminal background check would be good for 5 years.
Okay. So what, I mean, I'm going to ask this, but I think I know the answer. So the question is, what are the benefits DC Health anticipates from moving to the MPD program? But I guess it would be the continuous monitoring.
Yes.
You only have to apply once.
Yes.
Um,
Some of the delays, we're trying to identify where licensees and those renewing are having delays, and getting the criminal background check done is one of those places. This would take it out of the hands of the applicants and automate it to some degree as a continuous thing where we would just be alerted. So wherever we can automate a process so that it isn't requiring every renewal applicant to do something, will decrease the amount of time it's taking us to get them licensed and get their renewals in place in time.
Okay. Administratively, how does this work? So MPD would only alert you if there's a issue?
Yep.
Okay. All right. And then let's say my colleague in Judiciary and Public Safety takes this subtitle out, which means that there is no wrap back program that would begin in October. Like how important is this to you all?
It's pretty important to our licensees that they get an easier process than they currently have. So I would say requiring tens of thousands of doctors, nurses, psychologists, et cetera, to get a background check when the vast majority of them have done nothing that would show up on one is an important thing to stop doing if we can.
Okay. I'll take that to the.
And one of the positives about the wrap back is that currently when someone does their renewal and they do an updated criminal background check, it may still reduce a positive alert because of something that they previously disclosed that the board has already addressed. And again, it leads to delays. With wrap back, you're gonna get alerted if there's anything
It's
new.
perspective, not
Yes,
making us
so-
relitigate everything they ever did.
So it just keeps us, it just expedites the process and a better flow for the applicants.
Okay, that sounds good. Another non-lapsing fund that would become lapsing is for the Board of Medicine's fund. So the proposed budget would sweep 1.3 million in FY 26 and then 4.4 million in the out years from the Board of Medicine lapsing fund. How will this impact the ability of DC Health to process health licensing applications efficiently and accurately? So I guess she's not making this lapsing. She's just taking your money.
I don't think that's unheard of that it gets swept. So don't believe that's new. So we have managed within our budget with the money we have to date, but I'm going to let Adrena speak to what's happened in past years.
So historically, the agency has been able to manage within what has been budgeted, and any excess funds that were reported as fund balance have been swept probably over the past 5 years.
Okay, what
At
does
least
this
so.
normally go to? What are we normally funding? The staff.
Yes, it's staff
Okay,
and IT. It's the health licensing program as a whole.
all right. So again, if we're regularly swiping the excess balance, why don't y'all lower the fee?
The problem is the way the balance appeared in the past is that it would be a bunch of money that really was needed going forward. And we would adjust to try to make that fit. I don't know that we can't lower the fee, but I need a more reasonable, regular income flow to be able to estimate what the expenses are. It does change year to year to some degree.
Okay,
So it's not, the number of professional varies to some degree, and we still have the same amount of work to do. It's not, 20 fewer doctors does not leave me less of a person.
yeah.
So it's not a 1-to-1 exactly. So we'll have to see what happens
Okay.
in this year.
Another fund, Board of Pharmacy. So this would change it to a lapsing fund as well. Outside of license application fees, what are the other sources of revenue that goes into the Board of Pharmacy fund?
So most of it is licensing for the facilities and pharmacists and like the detailers, but also the notice of infractions. Those go into that fund as well, that are issued by the Pharmaceutical Control Division.
Okay, and what do we use this fund to support beyond licensing staff?
So it uses the fund to support the inspectors that go out to inspect the pharmacies, which is part of the licensing staff because they do initial inspections for any new pharmacies that come up, and that's part of the application process for them to get their license. But mostly it is staffing, and some of our like contracts for continue education. Some of those things come out of the pharmacy fund.
Okay. And so you don't feel like this change will have any impact on the operations of the board or the inspections going forward?
No, we'll have to see. I will say that money being swept at the end of a fiscal year is not unheard of. And that we have been using the fund kind of in that environment. I think we will have to see what happens in terms of how much is there at any given moment. It's not as consistent because it does have fines and other things in it, but we'll be in conversation with the mayor's office if we find that we need to change it.
Okay. All right. Everybody wants a compact. Everybody wants a compact.
It does make things easier, but we've done what we can.
Okay, so the National Counseling Compact, interestingly enough, has already named DC on their website as a compact state. Have we been participating in the compact thus far?
No, we have not implemented the compact as of yet. It did come before council and it did pass. So I think all the jurisdictions that passed the compact, they added to the list, but it is not operational at this time.
Okay, then they need to understand the difference between us passing it and us funding it because we haven't funded it yet. So, and you guys didn't send the money for that. Do you want us to fund it? I don't even remember how much the FIS is, but there's a fiscal impact.
We would like for it to be funded, yes, so that we can move forward with implementation.
Yeah, y'all should take some of that extra money that you have from the Board of Medicine and the Board of Pharmacy and lump that together. Adrian's like, nope. Okay, $164,000.
We'll talk.
Okay. I want to meet you guys where you are. We're broke over here. Just letting you understand that.
understand.
Okay, great. All right. Okay. No, we didn't see it, but I want to ask, does the proposed FY26 budget include any cuts to the staff responsible for inspections and licensing of health facilities?
No.
No. Okay, great. Now, so we heard testimony from the firefighters union, which don't always come to testify at your hearings. So this was significant. About the initiative between DC Health and the Hospital Association to
Yeah.
reduce ambulance wait times at emergency departments. They believe that you all aren't acting on the findings of this initiative just yet, and that there continues to be huge bottlenecks in the process. Can you provide an update on the status? How many hospitals are currently operating within the 30-minute or under wait time, and what more you all can do to help support hospitals in this endeavor?
Yeah. So one, I will just frame this, that is what we are trying to do, support hospitals in this endeavor. We, DC has been quite far from 30 minutes for a long time. And so we are trying to slowly move us back to a reasonable position. Part of the issue was that when we started to engage on this issue, no one was using, between the hospitals and EMS, we're using different metrics for what wait time was. And if you notice, if you imagine there are several times at which you could say the wait is over, the patient has arrived, the nurse has taken the triage, the patient has moved off the gurney, the patient has got a physician attached. various different points were being used. So we got something that we could all agree on that was much more of a national standard. And we have set up a system which we are watching this with all of the hospitals. We are informing them of their data at all the time and giving them kind of a real-time sense of when an ambulance has been waiting. Hospital leadership gets an alert when an ambulance has been in their bay for too long. So we are working with them and they are improving. The spring was a little bit interrupted by having a new hospital come on board and lots of other things kind of changed the landscape. But despite that, there have been improvements. They have just not been fast. We're about, I'd say about 6 months off from where we thought we would be, but it is not because no forward motion has happened. What I think people are looking for is a regulatory authority that does not exist. There is not an infraction attached to the amount of time someone is under one type of care versus another. And the system is one system. So the reasoning behind the lack of movement of a patient can be about a decision made in the ER. It can be about the flow from the ER to the floor or the flow from the floor out of the hospital. So bottlenecks happen at lots of points throughout the way a patient flows through the system. And so what we've been looking at is how do we identify what that point is that's actually causing this problem and how do we fix it? And so we have made some improvements. I'm going to let Dr. Hurley speak to that. But I do think we've made progress here and that they're looking for a more aggressive regulatory framework that we would have to write and create. And it does not make sense to ding people for being off of something that systematically they could not
Well,
contend with.
Dr. Hurley, as you're answering, like, what are we talking about here? 30, I guess, is the goal.
Yes.
Where are we averaging right now?
Yeah, so to put things in perspective, in January of 2023, we were over 2 hours as the APOT time.
The 90th percentile.
Yeah, for the 90th percentile. So 90% of all ambulance transports that were taken to the hospital, 90% of them were offloaded within 2 hours. And actually, it's like 2 hours and 7 minutes. Now we are down as of January of this year to an hour and 7 minutes. So it is going down. And if you look at the trend, which we can provide you a graph, there is a downward slope of the time. However, there are a lot of variables that come into play when these things, when you're doing this, because you have special events like inauguration where you have larger volumes and our system, was not necessarily built to manage as many people. So you have fluctuations based on volume, and you also have changes in injury patterns and illness patterns, like you have flu season, those types of things, which change the volume. So we have seen changes, and we have implemented, as Dr. Bennett alluded to, we have standardized the metrics. We've established benchmarks and clearly articulated goals and timelines. So the 30-minute goal is really for October of 2026. That was the time frame that we worked with the hospitals, hospitals individually, the DC Hospital Association, and DC Fire and EMS to agree that we cannot change this overnight. And this is like driving a cruise ship with a boat paddle. It takes a while for me to turn the ship, but we are turning that ship, and it is getting better. We have had direct engagements with hospital CEOs at the DC Hospital Association meetings. We've also had biweekly emergency department leader meetings where they are talking about what they're specifically doing within their hospitals to increase this. Because Dr. Bennett alluded to this, it is not necessarily just the offloading of the patient from EMS. It's all of the other systems on the back end. If the emergency department can't move the patient from the ER to the floor, or the floor can't discharge the patient to a nursing home or home, that creates bottlenecks in various locations. And so that bottleneck may not be exclusive to the emergency department. It may be systemic. And so we're looking at throughput systemically. And that's, one of the inclinations of us moving to the health systems and preparedness administration is really pushing these components together, where we're talking about how does the system interplay together.
Yeah.
I just want to say though, we are balancing two things. I would like every ambulance to be in service for every minute that they can be because people need to be brought to the hospital. At the same time, I don't want a patient off of a gurney where they have two qualified health professionals to go onto a bed
And sit in the hall.
unless they do also have qualified health professionals.
Yeah.
So I can't force the patient into the hospital unless the hospital is saying, we are here with the capability of taking care of that patient because they are already in a safe place.
Yeah.
So there are two things to balance there. I want the ambulance free, but I also want the patient to never have been out of a safe observational status.
Yeah. I mean, speaking in sort of this question about the emergency room department, and you guys are the public health agency. So I feel like some of this education in some ways maybe should come from you guys. Maybe not. Tell me if I'm wrong. In terms of better community education on when to go to the emergency room versus when to go to urgent care. I got the 45-day report from Cedar Hill. And I already kind of knew from some of the emails I was getting from folks that like people were just curious and kicking the tires on Cedar Hill. But I'm like, you weren't actually there for an emergency. You were there to take a look.
They did have a lot of low level patients, especially in those first
80% of
weeks.
their cases
Right.
in this
Would have
first
to be
45 days could have been handled at an urgent care.
Yes, we're
80%. So when you complained to me that you were waiting for 3 hours, it was like, well, you weren't bleeding.
And they do have to triage, so they can't just say across the room, you look good. They have to bring each of those people in and do vital signs and see how they're doing. So there is a time element baked in legally. We would ding them if they didn't do
Right.
it. So yes,
So
it has
true.
caused problems.
But I feel like we need to, we spent all this money to build these new urgent care centers. They haven't gotten necessarily the same level of promotion as the new hospital.
Mhm.
But I think overall, all of our hospitals would benefit from some sort of public education campaign that talks about there's a different way to go here.
We've
'Cause
been working with DCHA and they have agreed that that is something they want to push forward and
Okay.
that they will lead. We also know as we look at our health systems plan that we need more urgent care and more different places for people and more models of how people get chronic disease and other care on a more as needed or on your schedule basis. So we're looking at all of those things and you'll see some interventions in that space.
Okay. I even had a neighbor who was like, I think I have to go to the emergency room for stitches. And I was like, how deep is your stitch? Like how, or your
Mhm.
cut. And I was like, you do know urgent care can do stitches. Oh, I didn't know that. And I was like, yeah, you could be in and out if you just go do that as opposed to sitting in an emergency room and kind of figuring that part out. Similarly, a position in sort of the conversation around bottlenecks, but also a little bit different. We've got some hospitals who have had some patients who no longer need high acute
Mhm.
level of care, but there's no place to safely
Yes.
discharge them to. I know that healthcare finance has been a part of some of these conversations from the insurance standpoint, and I'm curious how, if at all, DC Health has played a role.
So we have not had a large role yet, other than sometimes mediating with health facilities that should perhaps be taking someone but aren't. But they do have to have some ability to say, I'm not capable of doing this and be believed. What I will say is that there are holes in our system generally. So if you look at the background of some of those patients, they are patients who are homeless and therefore might be safe at a house with a family member, but they don't have those two things. But they're not quite sick enough to need a nursing home. So we do have some holes in the level of care that's available. Others of them are international patients who are not US citizens, don't fall under Medicaid, don't. So we have some holes that people who either who are unhoused or undocumented can fall into where there isn't a step down for them that we can qualify them for. We're looking at what may be able to fit in that hole. That's part of our planning, which is partly why I want not just around facilities, but around who's in the community and what kind of care are they getting to look at whether that there are alternative ways we can deliver that care, but that is just a legitimate problem. Every hospital has some of them. There have been lots of innovative solutions across the country, and we're looking at what those might be.
Okay. In terms of health systems
Mhm.
work, are you all doing some sort of needs assessment in terms of where the gaps are in a more formalized way, or is this just based on observation?
We're doing both. So the health services plan has done a lot of that formalized work. And we're doing more on the ground observation as we get complaints and people are attempting to move people and we try to mediate. That is part of our role as the regulator, is to sort of see every time there's a problem, because they usually come to us.
Okay. Do you also do that for behavioral health in terms of systems too?
We're not connected to that entire system. But we do that at the hospital level, absolutely, looking at where patients are going and where they are not going. We have had some conversations between DBH, DC Health, and DHCF about step down care in that realm, where people need intensive outpatient or other care, and we don't seem to have those service providers as robustly as you might. There's kind of a ring
Yeah.
of them in Maryland.
No, I
not in
mean,
the
we had a hearing on this.
Mhm.
I don't see any investments in anybody's budget that moves us closer to where we should be going in terms of developing these things that we don't have that we need, whether it be on the pediatric side or the adult side, but the variety. And I'm gonna keep pushing on this because I do feel like it's super important. On this and sort of related and not, you and I have talked about this, but I'm gonna say this for the record because I want the public who is listening to know that I heard them. I've asked you guys to take a stronger look at St. Elizabeth's Hospital from your regulator role as a hospital, because that is a hospital. It is one that we run, but I don't want us to get into this. There's a perception or feeling that DC Health isn't going to do the necessary oversight for St. Elizabeth's because it is part of our government, as opposed to treating them as though you would treat every other hospital. And some of the allegations of the conditions and what is happening at St. Elizabeth's has me concerned. I'm not a regulator. You're the regulator.
Yeah.
It is a hospital. And so I'm asking that you guys lean in more.
We do treat them like other hospitals, and we do go there. I will say that across the board, we need to improve our regulatory framework around what needs to be reported and what happens when you don't report. Because a lot of the things that we're being asked to deal with, we were not informed of. And so, and I think the framework is not clear to all of our partners, and there aren't very clear consequences attached to it. So we need to shore up that part so that we have a better sense of communication, so that it isn't only when we're there at a normal survey or when a particular type of incident happens that we're getting much more information. That's part of what you'll see around why we want to be at least aware of the outpatient facilities, because then we get a call and we have no idea who you are. The same is true in the hospital. We know who you are, we go there, but we don't necessarily get the kind of reporting of incidents that you would hope for in order for us to play a regulatory role. So you will see that coming down the pike.
Okay. I want to ask a couple of questions about long-term care, which is normally a healthcare finance, but you guys kind of have a role there.
We do.
So the pre-hearing responses indicated that healthcare finance transferred 1 million in FY25 to healthcare finance transferred $1 million to you all for the CNA training
Yes.
through the high need healthcare scholarship program. It was granted to 3 training programs. How many CNAs have been trained through those programs with these funds thus far?
So some of the cohorts have not started. They're set to start this summer or in September.
Okay. The responses indicate that healthcare finance will increase its total transfer for workforce development. So 3.8 million in FY25, 5 million in FY26. how much of that is for the scholarships and then how much of it is for other activities?
I'm not sure of the dollar amount, that we would have to get back to you. I know that there is a plan to increase the amount of award, granted in FY 26 based on that increase.
Okay, I hope you guys do some evaluation in terms of the CNA programs on the testing piece. We've been on this ongoing journey, which I'm going to ask you about Credentia now as we are on our ongoing journey. Are you all making any changes to the contract to ensure that increased capacity to help as we're now investing in all of these folks to take these programs? We want to make sure that they're able to take the class, or excuse me, take the test on the back end.
So yes, we are currently working on updating the contract, but we are also working on some internal potential resolutions to the skills portion of the exam, because that's where the capacity issue is currently, where there's a current issue. It's based on the need for proctors. And so Credentia is working on hiring 2 full-time proctors for our region. So we hope that that change will help ensure that there's enough scheduled events for the skills portion of the exam.
Okay. Expedited licensure for our good friends from Maryland and Virginia. So during performance oversight, Director Hurley, you said you can get this done by the end of the year. Are we on track? End of the fiscal year, to be clear.
Yes, we are on track to have that happen.
Okay, just as a reminder, we required in the law that this be done by November of 2024. I've got firms that are waiting on us to do this so that they can more easily get their workers throughout the 2. Can you all let us know when it's done?
Will do.
Okay, thank you. All right, I'm gonna move to the last, hold on. Wait, I think I am, hold on. Okay, I'm gonna move to environmental health, but I do want to ask one question about, these raids that have been happening, raids, enforcement activity that's been happening with the food trucks on the National Mall. Are you guys part of that endeavor, along with DLCP and?
We're gonna ask Arian Gibson, who's my senior deputy at EHA. I do just want to say, one of the things we prioritized in healthcare licensing that maybe took a little precedent to go faster was making sure we had a pathway for the multi-state licensed nurses. Because we had reasons we couldn't be in the compact because of the way it did oversight, and fees did not work for the size of our state. DC.
Wait, I'm sorry. This is about
It's an aside.
Okay,
So
sorry.
while he's coming up, so that pathway is ongoing now. So there is an endorsement pathway online that people can do if they have a nurse compact license. That'll just get them a DC license. So
Oh.
that we prioritize starting faster because we knew we had a couple of critical nursing problems happening.
Okay.
So that is ongoing, and there were several hundred people who had gone through it last time Right.
Okay.
Who have a compact license now have a DC license
Can you
based on that.
guys-
So that is what we spent our recent springtime doing.
I mean, as an aside, can
Mhm.
you all get us some information on this? Because I have colleagues who want to do legislation on a nurse compact bill, which might not be necessary.
It's not necessary. So yes, we'll get you information on it.
Okay.
All of the hospitals have been briefed and are using it now. So we'll get you a briefing on where it is.
Okay. All right. No, this is great news.
Yes, it
It
is.
saves us time too. And I can stop taking those meetings. It's great.
But we'll get you a listing of how it works, who's done it, and who we've communicated with.
Okay. Is there anybody else you're thinking of reciprocity
So that
endorsement
gives
process
us,
with?
in terms of nursing, that is Maryland and Virginia. They're both compact states and it gives us the whole way around. Do you mean
No,
other professions?
Other professions. So, I mean, we've got some things going on with psych, we've got some things going on with nursing, we've got some things going on with doctors.
So the way we did that pathway was so that it could be used for other things and it gives
Sorry,
us-
now
No,
I'm
no.
interested now. Yeah.
It gives us a way to do a more rapid endorsement. So if you have a different license, we can give you a DC license without having to go through as intensive a process. So hopefully we'll use that same approach to do other things.
The only other profession this year that we are in a reciprocity agreement with for is physician assistants with Maryland and Virginia. And we are also moving forward with a potential reciprocity agreement between Maryland and Virginia for veterinary medicine.
Okay. Gotta help the vet, the animals. All right. Thank you. All right. I want to ask about another Budget Support Act title.
Mhm.
This is the Environmental Health Amendment Act of 2025,
Yeah.
which gives DC Health authority over the childhood lead poison
Mhm.
prevention program and medical waste. Okay. So the subtitle specifies that the goal is to reduce lead exposure of children. Now, the Childhood Lead Poisoning Screening and Reporting Act of 2002, so I guess this is the original foundational legislation for this, defines children as under 6 years old. Will DC Health use the same age cutoff?
That's the high risk group for lead exposure.
Okay.
So for the most part, it's orally taken in. So yes,
All right.
and pregnant women, sorry.
Okay, so DC Health will now be implementing this bill, which requires 2 screenings for each child before they turn 6. Do you believe that this is this is still the appropriate amount of testing? Or will DC Health plan to amend this in the future?
It's 2 by 2 in practice. That is what we want kids to have. Those are the prime years that you have lead exposure. We do testing outside of that if there is a known exposure risk. So somebody did construction and you have paint chips everywhere and the child is 4, that is still someone we'd be interested in doing screening for. But the main screening goal is 2 by 2. And that is a national standard that we do adhere to.
Okay. Okay, so DC Health is now, you will be
Mhm.
the agency to
Yes.
impose the fines and penalties for violations of this bill. Will you all establish?
Go ahead.
Oh,
Arian Gibson, Senior Deputy Director for Environmental Health.
okay.
Yeah, so DOEE still retains the fines and penalties. We are the case management portion of it. So we're helping to facilitate getting the lead screening and following up with the family.
So the fines are about the lead source.
Yeah.
And they are still retaining everything related to the source. We are very much focused on the people. That's what the Environmental Health Administration is trying to do. It's wherever we are not doing as much as we could around how people are impacted by the environment. That's what we're trying to shore up. And we're going to add some elements to this program that I think will be helpful in that way.
Okay, so DOE is still responsible for the physical building and
Yes.
inspection portion, or maybe not building, but
It might be playground, could be whatever,
Yeah.
the source.
whatever the
finding
source,
the source,
is, and then you all deal with the
the children
after.
and families.
Okay. In terms of at pediatrician offices, et cetera, obviously this is normally where the screenings take place. If there was a concern that a particular practice wasn't doing the screening,
Mhm.
then is that a DC Health question?
It would be. So
Okay.
that's one of the things we want to bring to the program is our relationships in terms of CME or regulatory enforcement with different facilities and providers so that we can have a more complete relationship with them on this. and to be able to use public health nurses or others to do more extensive screening of other kids who might be exposed or things like that. So those are the two elements that I'm hoping we will be able to expand.
Okay. All right. Animal control. I'm ending with animals and pests. Rodents.
We have bed bugs too. You can do all the pests.
Oh, wait, before we get there, she's told me to go back to ask about food
Yes.
before we talk about pests and rodents.
Thank you.
Okay, I want to go back to my question about the food trucks. Yeah. Food truck enforcement, which has stepped up. I had some conversations with Director Crow. They had some concerns about some activity, extracurricular activity that was happening out of some of these trucks and it needed some additional pieces. But she also said this has to be a combined effort across the board. And so I'm curious how you all have been part of the efforts.
Yes, so we're part of the work group. It's SDOCP, DPW, National Park Service, a bunch of different agencies. I think most recently we went out there towards the end of last month, and we had an enforcement activity. But it's something that's we meet about it at least quarterly, and we're going to continue going out over the summer.
Okay. All right. And in terms of staffing for your inspectors for food facilities, how are we doing?
So we're fully staffed.
This
we-
is great.
Yes, yep.
You haven't
We're
been
fully
there in a
staffed.
minute.
Yes.
So this is wonderful.
Yep.
Okay. And we're ramping up to meet our goals in terms of our annual reviews of every establishment.
We're trying our best. As you know, we do it on a risk based schedule. So the high risk ones, we will get to the high risk ones, but some of the gas stations and things like that, they're lower risk. We may not get to.
Telling you, 7-Eleven be cooking food too. Not that I would eat at a
Let's see.
7-Eleven hot dog, but nonetheless. Okay. All right. Animal control. So the proposed budget for the contract is 8.5 million. The spending for this contract has varied for the past 3 fiscal years as we sort of transition. Fiscal year 25, where we're currently, is at 11.7 million. So 8.5 is a reduction, but it's still not where we were in 24, which was 5.8.
Except we weren't really, because that was what was on the books, and then we ended up having to ask for more at the end.
Of 24.
Yes.
Okay. So do we believe that the
5.8.
8.5 is the right size?
Yes.
Like, are we now officially right sizing to go
Yes.
forward?
It was a transition year, but yes.
Okay. Do you anticipate any spending pressures in this contract for 26?
No.
All right. So Brandywine Valley's up and running and full.
Mhm.
Full being not just full as in full of life, but like they've got
Fully operational.
they've got a lot of dogs full
Yes.
in the New York Avenue site. So we've received some complaints from some staff and volunteers about being bitten by dogs. Do you all have a bite? Do you track bite incidents? And do you feel like there's been any increases in comparison to the last contractor?
Yes, so our epidemiologists track bite incidents. There has not been a significant increase in incidents since the last contractor, but we do track the bite incidents, and our EPIs and our investigators follow up with the patients.
Okay. One of the big issues that we've heard about is just like, again, getting to sort of this overcrowding piece with the New York Avenue site. So we've got some dogs who are being kept together in confined areas, kept out on the runs for a longer period of time. Some of this can be alleviated once this new location is built out. So I understand there has been a slowdown in construction. What's the status update and when will DC Village be complete?
So I just want to clarify, the animal holding areas of that DC Village site have been operational for some time now, and there's been a transfer of animals that's happening over time. So there's no reason to be crowded at New York Avenue. What isn't done and has had some slowdown because of supply chain issues, whether that's tariff or just supply chain, has been the staff area, the adoption and kind of administrative areas, and the medical facility. So those are planning to go online in the next few months as soon as we get some of the equipment needed. But there is room to hold animals, and animals are there.
The major issues are that we're waiting on is HVAC, and I forgot what the piece is for, but for the medical suite, has to be zero pressure for that suite. So those are the two major things that we are waiting on.
Okay. In terms of DC Health's oversight of this contract, what are the significant differences that you all have in place now that you didn't have in
Hello?
place with the previous?
Hello?
Is that Clover, or is that someone else online?
Oh, that is
Hello?
Clover. Clover, you were.
Clover.
No, you
That
just
is
called-
not me. I'm not sure who that is.
Oh, okay.
Hey, you called me.
It didn't sound like her.
Hold on one second. All right.
Alrighty. Start that question again. for me.
Yeah, a
Sorry.
little, some wires got crossed there of somebody's phone call. All right. My question was around DC Health's oversight, in terms of the performance of this contract versus what we used to do in the past. Because past is a prologue, right? I'm already starting to get these anonymous emails from people who are at Brandywine in the same sort of way that they used to send the emails about HRA,
Mhm.
right? I'm not in your facilities every day. You're not in your facilities every
Right.
day. So how are you all providing oversight to ensure that expectations are being met, and the contract pieces are being met in a way that might be different than what you did with the previous vendor?
Yes, so we are, well, we cleaned up some of the aspects of the contract for it to be clearer, but it pertains to oversight and inspections. We're much more hands-on with this one. I think we've already been in both facilities this calendar year about 5 times to do walkthroughs and to check. Most recent one was last week. We were at both New York Avenue and DC Village. So we're out at the facilities doing walkthroughs and inspections much more frequently.
Okay. Speaking of sort of the new site, as we were kind of making this transition happen, we had always been talking about DC Village as a temporary,
Mhm.
but now it seems as though you all have shifted to calling this the permanent.
Yeah, there really was not a way to run a temporary facility without doing very expensive drainage and air handling, which made it prohibitive to then say we were going to do very expensive drainage and air handling somewhere else. So the facility is equipped that it can be good for the long term. The decision to go to it, we didn't do anything we didn't have to do. So you have to have the trench drainage, or you will not be able to function with waste management and cleanliness. And we had to have a very high level air handling, which was expensive. So putting that in anywhere would have been prohibitive, and we couldn't have any animals in without it. So it did not work out fiscally to make sense to have the biggest expenses be unavoidable and then just not build out the rest of it. So we decided to build out the rest of it.
Okay, but
And we didn't have
The
a choice
DC
about having a temporary place,
Yep.
right? Because our contract ended and we sort of were left without a home.
right, but the DC Village location is still not great for adoptions unless that's just going to be on the back burner.
Yeah, we have talked to Brandywine about having a in-town satellite site, sort of the way we do with many other services. So that is the main site, and then having others. They have one that they've partially built out that we are working with them on. If they can finish that, that would put us in Ivy Village. So that would help this. Not, I would say Ivy Village,
I was
sorry.
like, Ivy City?
Ivy City.
Okay.
Sorry,
I
DC
assume that's what you
DC
meant.
Village, Ivy, it got a little confused there for a second, but that would put us in Ivy City. So we are aware that we're going to need to have a site that is not as far as DC Village for adoptions, but most people are uh, likely going to need to come to DC Village for a little while until that happens. And so we're looking at how to move that forward.
Okay. I hate that this is my final question, but let's
about
talk
that
about
one.
rats.
They're a popular issue.
Okay, so we heard from the Coalition for Responsible Rat Management. Yes,
Yes.
it does exist. They praised DC Health's efforts to reduce the use of rat poisonings in the district that can be harmful to pets and to humans. What specific efforts are you all taking to curb that product usage? And what advice or public health messages are we sending out to residents around using these products? The witness testified about how someone had used a pretty strong rat poisoning and just like poured it all over the alley without obviously consulting neighbors about this, which, you know, they have pets and otherwise, and, you know, anybody, right, walking through the alley who could have been exposed to this.
Yes, so we use Diatrac, and it's essentially a powder that we actually pump in the rat burrows. So that wouldn't affect small children. But we do consult with, because what we do is we do petitions when we're going to do a block. So we get everybody on that block to sign off on it. And we kind of talk to the residents about what we're doing and what the chemical is and things like that prior to serving that petition and doing that whole block.
Okay, can somebody request their block be done?
Yes.
Yes, that is how it gets done.
Yeah.
But I will say that the rat poison, especially what they sound like they're talking about, are what's sold commercially, and that people can buy those at retail, and then make decisions that maybe aren't the best health decisions for everyone. That isn't regulating, hasn't been in our wheelhouse, but we
Mhm.
also weren't environmental health before. So that is something that would be the kind of thing we want to start to move forward into, is to talk to people about what they're doing and how calling us is probably the better option. But yeah, so we use a less dangerous methodology than you could buy at Home Depot,
Okay.
but it is legal to buy that.
We'll use this as a public health announcement for right now. Go ahead.
Yep, and we prefer to do it, do a petition rather than do a single, and we will come and do a single home or single resident.
No, but
we
rats
prefer,
don't stay at one place.
exactly. So we prefer to do a block at a time to really be effective.
Okay. Hang on one second. Okay, that was not on my last question. There's one more. So there's a bill that we moved, that you all introduced on Radiation Protection Amendment Act, or something to that effect. Anywho, there was a fuss associated, but you all didn't fund it. So how would you like us to proceed on this legislation? The bill would give you all the authority on non-ionizing radiation.
Yes, that is a very important bill, and it crosses both HISPA and EHA. So yes, we definitely are going to move forward with that.
Okay.
Yeah.
So we would need to know if you guys are saying that there's no longer a FIS,
Okay.
so that we can remove the subject to appropriations language that would enable you to move forward with it. But, okay, because right now it's subject to appropriations. And so, yeah, since it's a bill that came from you, we're just gonna hope on that front. All right. I asked you a lot. There's a lot going on. I want to thank you, Dr. Bennett, and your team for providing testimony and information to the committee. If we have any additional questions, we'll certainly reach out to you. just so you know, for some of the follow-ups, it's gonna have to be a quicker turnaround.
Yes, we understand.
Because we mark up next week.
Yep, we know.
Oh my God.
I have two quick follow-ups. that
Monday.
We could take off the list.
Oh, great. We love it.
For Healthy Steps, the 300K, I confirmed with the program that actually went to Unity for Healthy Steps. You
Okay,
had
but there were
mentioned it
two
was
lines.
listed as, right, so the 1,050K is grants, and that was Unity, Children's, and Community of Hope, I believe. Child will have to correct me. But the 300K that was listed as TBD went to Unity
Okay.
for Healthy Steps.
All right. And what was your second one?
And then the other update, you asked how many positions were frozen for the vacancy savings in the FY25 supplemental. There are 20 positions between local and SPR.
Okay, great. Look at that. Crossing things off the list, but we might have some other pieces. So I want to sincerely thank all of the public witnesses who testified in person or submitted written testimony online on the DC Health budget. This is definitely a challenging time for our country in terms of public health. And I deeply appreciate the dedicated DC Health employees, the healthcare providers, the organizations and residents continuing the critical work of protecting our health infrastructure, preventing and treating diseases, and of course, addressing some of the social determinants of health. What I will say to the public is we're going to do our best.
Yep.
That is, I cannot make promises, but we're going to do our best. But this concludes today's hearing. So if anyone still wants to submit testimony for the record, the record will remain open until Monday, June 23rd at 5:00. We'd encourage you to get it in earlier than that because we will have voted before then. So update your testimony or upload it to the hearing management system website on the council's website. So the Committee on Health will meet next on Monday, June 30th. No, Monday, June 23rd, at 3:00 to discuss and mark up our FY26 committee budget report and recommendations. Although technically we're meeting today at 1:00 for a markup on several nominations to health licensing boards. Board of Rehabilitative Therapies. Okay. Time is 12:27. This hearing is adjourned. Thank you, everyone.
Thank you.